So that's what we're going to dive into in this video. We're going to start with basic concepts, literally what's a ventilator, positive pressure ventilation, PEEP, respiratory rate, tidal volume, all that good stuff. We'll then go into more advanced topics like different mechanical ventilation modes. We'll talk about alarms, scalars, and loops. We'll talk about more advanced topics like driving pressure. We'll talk about some of the more advanced ventilator settings like I to E ratios and flow rate and all that jazz. So a lot of good stuff packed into here. As an FYI, this is never intended to be acted upon as medical advice. Stick around to the end of the episode for the full disclaimer if you have an interest in that. Again, shameless plug, this study guide as well as practice questions will be on our Patreon page, which will be listed in the video description if you want access to any of that stuff. We also have a weekly newsletter, and you can see this both in YouTube form or listen to it in podcast form. So no more shameless plugs. Let's dive into the concept today. So mechanical ventilation terminology and concepts. Starting with just basic concepts. So a ventilator, what is a ventilator? I think all of us inherently know what that might mean, but to spell it out, a ventilator is the actual machine that is delivering the gas to the lungs, and it's under positive pressure. And this is a machine that isn't ever intended to fix the lungs. It's intended to give them time to heal from whatever their primary kind of injury mechanism is. So there's all that stuff with COVID about ventilators kill people, et cetera, but a ventilator is not meant to heal someone. A ventilator is we have no other option. You are going to die without this machine to keep you alive. And by putting you on this machine, we hope that it provides you with enough time to heal from your underlying illness. Positive pressure ventilation is a concept where gas is being delivered to the lungs while under pressure. Okay, positive pressure ventilation. We're ventilating the lungs under pressure. This can be a BiPAP or CPAP mask. You have a sealed mask on the face that then provides gas to the lungs under a certain pressure. In positive pressure ventilation modes, exhalation usually occurs passively. Okay, think about that. Exhalation occurs passively. So in all these modes, you provide an inspiratory pressure. Sometimes you set the inspiratory pressure. We'll talk more about that. Sometimes you set a tidal volume, but that volume, when it's being pushed into the lungs, generates a pressure. But all the exhalation that occurs happens passively. All right, tidal volume. The tidal volume is the actual cc's of air that is being delivered with each breath. It's usually abbreviated TV. So it's the volume of gas delivered with each breath. And on a ventilator, we're typically targeting 6 to 8 cc's per kg of ideal body weight in adults. The ideal body weight is something you have to calculate based on height. This isn't their actual weight. This is their ideal body weight based on their height. The way we do it is we honestly just pull up MD Calc on the internet and you can calculate the ideal body weight. But there's lots of charts and stuff out there too. So that's the tidal volume. In a volume control mode on a ventilator, you set the tidal volume. Okay. In a pressure control mode, you set an inspiratory pressure, and that inspiratory pressure generates a tidal volume. We'll talk more about that too. The respiratory rate, this is the number of breaths delivered by the ventilator per minute. We set this. This is the respiratory rate. It's breaths per minute. Fraction of inspired oxygen, also known as the FiO2. This is the percent of oxygen in the gas mixture that's being delivered to the patient. This is often what we set to. It goes from 21%, or 0.21, so 21%, also known as 0.21, all the way to 100%. Why is 21% the lowest? Well, that's the FiO2, the fraction inspired oxygen of just atmospheric air. That's what we're all just breathing right now. So we don't put the oxygen lower than the lowest oxygen you would just breathe if you were breathing on your own. Okay, PEEP, or positive end expiratory pressure. This is an important one, and it's a concept that is not that hard to master, but you do have to just think about it for a minute. So this is the pressure that is maintained in the airways at the end of expiration. The pressure maintained in the airways at the end of expiration. So what this means is that even when a person is expiring, the PEEP is the pressure that is always there. Now, when they get an inspiration, there's usually more pressure. But even at the end of expiration, the PEEP is always there. And we set this, the quote unquote lowest PEEP that people use is 5, but you can set a PEEP of what you like. And the goal here is that it prevents alveolar collapse. All right, because if the PEEP went to 0, if there was no pressure and you let a patient fully exhale all of the air out of their lungs, well, whatever the exhalation volume is, we should say, and there's no pressure left, those alveoli would collapse. And then when you push a breath back in, those alveoli will be kind of ripped back open, and it can lead to something called atelectatrauma. Atelectasis being that collapse of the lungs, atelectatrauma being what can happen if you have too much alveolar collapse and reinflation, collapse, reinflation, collapse, reinflation. All right, the peak inspiratory pressure. We actually have a dedicated video on peak inspiratory pressure and plateau pressure, so this is not going to be a deep dive like that was. Again, check out the playlist. Sorry, our allergies are getting us today, but check out the plays for a detailed dive. But the peak inspiratory pressure is essentially the highest pressure achieved during inspiration. So this is often shown on the ventilator with each breath if you're in a volume control mode, okay? Because the volume control mode, you set the tidal volume, the TV, and then when that tidal volume is pushed in, it generates a peak inspiratory pressure. And the ventilator usually shows this number. And this is usually a reflection of both airway resistance and lung and chest wall compliance, right? It's the pressure generated when you're pushing a breath in, and it's going through those airways. So the airway resistance generates a pressure. Then it gets to the alveoli, right? And the alveoli have to expand, and that requires pressure too. So, it is the sum of the airway resistance and the alveolar pressure. When you pressure breath in through a trachea, it goes into the bronchi, into smaller bronchioles, and it inflates the lung itself. Whereas the plateau pressure is actually the pressure measured during an inspiratory pause. So there is no flow. That's a really important concept. There's no flow. So the plateau pressure, you actually hit a button on the ventilator, again, assuming you're in a volume control mode, and it's an inspiratory hold is what's it is called, or an inspiratory pause. So you hit the inspiratory hold, and it essentially the ventilator gives a breath, and then it holds. There's no flow of air. The whole system's kind of frozen. The air that is in the lung stays there, and it records the pressure generated just by having that air in the lungs, okay? And that's an estimation of alveolar pressure or lung compliance, which makes sense, right? Because airway resistance is no longer part of the equation because the breath is just being held. There's no flow of air going through the airways at the time. So it's really just what the alveoli, as they're kind of trying to collapse down on the air that's already there, the pressure that's being generated. So this is an alveolar or lung compliance pressure compared to that peak inspiratory pressure, right? Which is where you push that breath in and it has to go through the airways, which generates resistance, and expand the alveoli, which generates pressure. All right, compliance. This is going to be the last kind of piece of terminology in the introductory section here. And compliance, we've used it a lot. We keep saying lung compliance, lung and chest wall compliance. Well, what is compliance? Compliance is the change in volume per change in pressure. All right, the delta V over the delta P. So change in volume over change in pressure. And that makes sense, right? Because the compliance is, for lack of a medical term, kind of how stretchy, how compliant those lungs are. You can think of like the classical, just out in the world definition of compliance. It's how easy it is for those alveoli to expand. So if it's easy to make them expand, it should not, when you expand them by increasing the volume in them, it should not generate a large pressure. So the compliance should be higher. They should be more compliant, right? The denominator is lower and the numerator is higher. So a higher compliance means kind of, stretchier or easier to inflate without generation of much pressure, that change in volume over that change in pressure. There are two different types of compliance talked about. There's static compliance and dynamic compliance. Static compliance is measured at zero flow. Okay, zero flow. And the static compliance is essentially the tidal volume divided by the plateau pressure minus the PEEP. And if you've watched all of our lectures, and this is an advanced topic, right? If this is kind of above the level, just ignore this. We'll get back into the bread and butter. But the plateau pressure minus the PEEP is this thing called the driving pressure, which we've talked about before. So tidal volume divided by that is static compliance. There's no flow. And because there's no flow, that's why you take the plateau pressure, right? Because as we said, the plateau pressure is measured at an inspiratory hold with no flow. Okay. Whereas dynamic compliance is measured during airflow. So instead of the plateau pressure, you take the peak pressure. So that equation is the tidal volume divided by the peak pressure minus the PEEP. But these are more complex equations. The concept is compliance is related to the change in volume divided by the change in pressure. All right, that's a more important equation to remember rather than kind of static and dynamic compliance. That starts to go down the road of complexity there. All right, what about common ventilator modes? So here we'll break it up into kind of mode, name, controlled variable, and description. Sorry, grabbed a little drink. So starting with this, these two that are CMV and AC. So CMV is continuous mandatory, and AC is assist control. And we really only use, at least traditionally, someone correct me in the comments if you're using continuous mandatory often, but we're really using assist control mostly. And assist control means that a patient can trigger their own breaths. Okay, so when a patient is in volume control or pressure control, we don't say this often, but it's usually assist control volume control or assist control pressure control, also known as ACVC or ACPC. And that just means if it was continuous mandatory, the ventilator would just give them the breaths that we set the respiratory rate at. But assist control allows the patient to trigger those breaths, which helps with ventilator synchrony, right? If a patient can say, hey, I'd like to take a breath now, and then the ventilator says, okay, I'll help you with that breath, and it assists them, that's going to be much better than the ventilator just being like, I don't care if you want to take a breath or not. I'm going to push a breath in and push a breath in and push a breath in. I'm just at my own pace. So these days, I think assist control is the primary mode we all use, and it can be assist volume control or assist pressure control. All right. And as we just said, it delivers a set tidal volume or a set pressure at the respiratory rate, but the patient can trigger the breath if they're able to. Now, the ventilator will still give them a breath. If I set the respiratory rate at 20, right, and I'm in assist control mode, if the patient takes 20 breaths, the ventilator will just let them trigger all 20 breaths. But if the patient only takes 10 breaths, the ventilator will give them an additional 10 breaths to make the 20 that we set. All right, SIMV is called synchronized intermittent mandatory ventilation. This is not widely used anymore. I personally don't really ever use it actually. But what this is it's a mode where the ventilator delivers the mandatory breaths that you've set, and it can synchronize those to patient effort. But if the patient wants to take additional breaths, let's say I set the respiratory rate at 14. Okay, for 14 breaths, the ventilator will assist that patient. But if the patient wants to take 24 breaths, there will be 10 breaths that the ventilator will not assist the patient in. That's just the patient tries to suck air through the endotracheal tube. And this used to be used as kind of a weaning strategy because you could decrease the respiratory rate, which would then mean the patient had to take more of their own breaths. But it's not widely used anymore. My humble opinion is that the evidence doesn't suggest it's helpful. But yes, it is something that you could set, and you will still hear it. And some of the folks out there who have been doing this a lot longer than me maybe used it more or still use it more because they're comfortable with it, but not part of my practice. But yes, this is where the ventilator will sync to the patient's effort for your set number of breaths that you set on the ventilator, the set respiratory rate. But any breaths beyond that, the patient has to take on their own. Whereas something like assist control, even if I set that respiratory rate at 20, if the patient takes 30 breaths, the ventilator will assist them for all 30 breaths. So if I set that, tidal volume at 500, and the patient wants to take 30 breaths, for all 30 breaths, the ventilator will assist them and try to give them a tidal volume of 500 for all 30 of those breaths. Whereas again, in SIMV, if I set that ventilator at 20, and the patient wants to take 30 breaths, for 10 of those breaths, the ventilator will not assist them at all. The patient will just kind of suck in air as much as they're able to. PSV, or pressure support ventilation. This is where the patient has to trigger all of their own breaths. This is a mode we often use when we're trying to see if a patient can be liberated from the ventilator or extubated. You'll put them on a pressure support trial. Now, there is usually an inspiratory pressure, and this is an important concept. It's a little tricky, and again, this is just an introduction to the nomenclature. But on a pressure support trial, you will have a PEEP. Remember, a PEEP is a positive end expiratory pressure, and that PEEP is typically 5. But you also will have a set inspiratory pressure. And it's usually, 5 above the PEEP, or you can use 7. You can set it to whatever you want to. And this is a little extra inspiratory pressure the ventilator will give when the patient takes a breath. And the thought here is that it's just enough pressure to help get past the airway resistance of the endotracheal tube, right? The endotracheal tube is, for all intents and purposes, a big straw. And a patient trying to suck air in and out of that straw is going to meet resistance. Try breathing in and out of a straw, right? It's hard to do. So the inspiratory pressure that you set is just supposed to give a little extra pressure to overcome that resistance. But all the breaths in pressure support mode are triggered by the patient. The ventilator will not give them any breaths. All right, CPAP is continuous positive airway pressure. This is essentially spontaneous breathing, but you just set a PEEP. People use CPAPs at home and things. This is just an end expiratory pressure that is set. Everything else the patient is doing themselves. All right. Ooh, APRV. This is really complex. We have a whole a whole episode we're putting out on APRV. It will be already out by the time this episode debuts. We suggest you just check out that episode because this is going to be too hard to explain quickly. It stands for airway pressure release ventilation, and it's essentially a time-controlled high pressure with intermittent pressure releases to facilitate ventilation. But that probably doesn't make sense when I just speak it that way. So definitely check out that episode if you have an interest. All right, what about key ventilator settings and parameters? So key ventilator settings and parameters, there's a couple things that are important to note here. The biggest one is the I to E ratio. This is the inspiratory to expiratory ratio. And if we think about this, this is essentially the amount of time a patient has to inspire on the ventilator and expire. Because we're setting a respiratory rate, and that respiratory rate has to be given within a minute. That's what we're saying. So if I set a respiratory rate of 30, that means that the ventilator has to give 30 breaths in each minute, which means on average, that breath's only going to last about 2 seconds each. So the I to E ratio is, okay, if I can only give a breath in 2 seconds, how much time is going to be inspiration versus expiration for that 2 seconds? And a normal I to E ratio, if you just think about yourself breathing, we spend a little more time expiring than we do inspiring, because inspiration is active. Even spontaneous inspiration, our diaphragms contract, and that causes inspiration, whereas expiration, our diaphragms just relax, and that expires. On the ventilator, though, inspiration is active in the sense that we're pushing that breath in. Expiration on the ventilator is essentially we stop pushing that breath in, and the patient just exhales at whatever pace they do. So normal I to E ratio is something around 1 to 2. So that means, let's make this easier math. If I set a respiratory rate of 20, that means let's give 20 breaths in a minute, which means there's about 3 seconds per breath. So if I have an I to E 1 to 2, it's going to be 1 second in inspiration and 2 seconds for expiration. And this gets really important for things like auto peeping or breath stacking. Again, we have an episode on that. We won't dive into it here, but you can adjust this I to E. You can increase the amount of time they're in expiration if they have something like obstructive lung disease, where you have a much more prolonged expiratory phase. All right, flow rate. So flow rate is the speed in which gas is delivered during inspiration. Units are often liters per minute. And this matters because it can be related to ventilator synchrony. Patients sometimes want more flow than they're able to get on the ventilator, because the ventilator says, okay, I'm just going to give this much flow of gas over this time frame. But if the patient is saying, like, taking these big robust breaths and they want more flow, it can lead to ventilator desynchrony, which can cause issues. So sometimes they need more flow than the ventilator will give them. And flow rate is a bigger problem in volume control modes, because in volume control modes, we're saying we want a certain tidal volume, right? A certain milliliters of volume given with each breath. And we're saying we want a certain number of breaths over a minute. And each breath then represents a certain amount of time. And that drives the flow rate in volume control. So if I just, let's see if we do easy math. If I set the tidal volume at 300 milliliters, and I set the respiratory rate at 20, which means there's about 3 seconds per breath. That's going to be, let's see, about 100 milliliters. Wait, but this is just for inspiratory, right? So 3 seconds per breath. Let's say the IDE is 1 to 2, which means there'll be 1 second of inspiration for every 2 seconds of expiration. So that's going to be 300 milliliters per second is the flow rate. All right. And if a patient wants more than that, it can lead to ventilator desynchrony. So in volume control, flow rate can be something really important to think about if you're seeing flow starvation. We actually have talked about that in episode 2 on desynchrony. Again, check out that playlist. Inspiratory pause or inspiratory hold. This is how you get the plateau pressure. It's a button on the ventilator. It essentially gives a breath and then pauses, so there's no flow. We talked about that already. Trigger sensitivity. This is something people don't think about all the time, but the ventilator is actually set to be sensitive to a certain degree for when a patient wants to take a breath. I feel like I explained that poorly. The ventilator essentially has a threshold. It can either be a pressure threshold or a flow threshold, because we said most of the time now we're using assist control. An assist control supports patient-triggered breaths. But what does triggered mean? How does the ventilator know the patient is trying to take a breath? And that's where trigger sensitivity comes in. There's a certain threshold. The patient has to mobilize a certain amount of pressure or flow that the ventilator detects, that then triggers the ventilator to say, oh, okay, you want to take a breath. Let me give you the tidal volume of 500 that the person set on the ventilator. And this can be adjusted. There's a lot of complexities here. This can be important for breath stacking and auto PEEP and all sorts of stuff. But some patients need changes in their trigger sensitivity to help with ventilator synchrony. All right, rise time. This is the rate or time it takes the ventilator to reach a set inspiratory pressure in a pressure targeted mode. So this would be in pressure control. The rise time is essentially how fast that ventilator gets to the inspiratory pressure that you set. So this is not relevant for volume control modes, but this is something that's relevant for pressure control modes. All right. Monitoring and alarms. We're going to fly through this because waveforms, there's 3 waveforms we talk about. We have episodes in all 3 of these waveforms. The one that's usually kind of on the top is the pressure versus time. The one in the middle is usually flow versus time, and the one on the bottom is volume versus time. If we're in a volume control mode, pressure versus time usually looks something like this. Right, this is what the scalar usually looks like. Flow versus time usually looks something like this. Oop, hopefully we didn't mess that up. Volume versus time usually looks something like this. Wow, these are really bad scalars, but check out our other videos to look more at these. There's a lot of rich data you can get from these waveforms or scalars, but they're very complex too, and they're different between pressure control and volume control. The scalars look totally different, which is something that you should note. Alarm types. High pressure and low pressure alarms happen not inconsistently. High pressure alarms, which essentially the peak pressure is too high. This can be from secretions, bronchospasm, decreased lung compliance. Low pressure alarm, this is usually a disconnection or a leak. This can be really important to note. Sometimes the cuff on the endotracheal tube is ruptured. Sometimes the endotracheal tube came off the connector to the ventilator. So low pressure alarms are things where you should trace the circuit really well, from where it plugs into the ventilator all the way to where it enters the patient's trachea. High or low tidal volume alarms come on all the time. Sometimes it's a circuit issue if there was a leak. Sometimes it is a patient issue. And then apnea is essentially when the patient's not taking any breaths. You can get an apnea alarm. Advanced terminology. I think we're getting into close to the end. There's, advanced terminology, then troubleshooting. Advanced terminology starts with driving pressure. We have a whole episode on driving pressure as well. This is the plateau pressure minus the PEEP, okay? And it can be an indicator of kind of lung alveoli distension. The goal is to keep it less than 15. Auto PEEP or intrinsic PEEP or breath stacking are all concepts that describe or give a name to the retention of air at the end of expiration. Again, this is an easy topic that sounds confusing when you just hear it for the first time, but when a patient breathes in, if they breathe in 500 cc's of tidal volume, but for whatever reason, they're only able to expire 450 cc's before the ventilator gives them the next breath. That means there's 50 cc's left in their lungs. Then the ventilator gives them a breath. right? So now they got 550 cc's, even though you only wanted them to get 500. They breathe out again. They can only breathe out 450 cc's. Now they have 100 cc's left in the lungs. Again, the ventilator gives them another 500, so on and so forth. So this is auto PEEP or breath stacking. We see this a lot in obstructive lung disease when patients need a lot more time to exhale. And we, not to be a broken record, have a couple episodes out on that too, so check it out in that playlist. Permissive hypercapnia. This is the concept where we allow an elevated amount of arterial carbon dioxide, PaCO2, as a way to reduce ventilator-induced lung injury. So in our patients with ARDS, this is something we do. We really want to make sure those patients aren't getting barotrauma, which is where you get kind of over-distension in the alveoli causing damage. So we will drop their tidal volumes lower, 6 cc's, 5 cc's per kg, target a certain plat pressure. We have a whole series on ARDS too, so check that out. But we'll allow them to have some permissive hypercapnia. We won't try to aggressively make their carbon dioxide normal because by doing so, we'll cause more lung damage. So instead, we let the carbon dioxide stay a little high if it means that we can have better control of any injury to their lungs. Recruitment maneuvers, we don't do these very often anymore. This is the idea where you can transiently increase the airway pressure, right? So increase their inspiratory pressure for a certain amount of time to try to recruit collapsed alveoli. There's been some trials on this, and the trials don't show that improves outcomes. It actually increases risk for things like pneumothorax and ventilator-induced lung injury, et cetera, et cetera. Hemodynamic instability was an issue in these studies. So we do not do recruitment maneuvers, at least not typically anymore. Pressure volume loops. This is a loop you can get on the ventilator. We won't talk more about that. It can be helpful with like when there's overdistension or collapse of alveoli. Electrical impedance tomography. This is not something that we use, but it can be used to monitor kind of regional lung ventilation. Ventilator-associated lung injury or ventilator-induced lung injury is another way you'll hear people talk about it. And this is injury to the lungs from mechanical ventilation. We got a whole episode on this: barotrauma, volutrauma, atelectotrauma, or biotrauma. And then esophageal pressure monitors. Some shops have an esophageal probe where you can do esophageal pressure monitorings, which can help you understand something called the transpulmonary pressure. Troubleshooting and clinical pearls. I'm going to leave this here in case you want to look at it. This is a little outside of this video, but I wanted to include it here because it helps you understand kind of plateau pressures, PEEPs, auto PEEPs, ventilator desynchrony, how to wean, which are all separate episodes. But for the sake of comprehension, it's here if you want to pause and take a look at it. All right, and the last thing here is we did include a glossary of these abbreviations so that you have them. Again, this whole thing will be in study guide version on our Patreon page. But this is a nice glossary of abbreviations if you work in the clinical arena to give you a reminder of these different things. So, introductory settings on the ventilator. Some of this is ventilator mode dependent, but let's just start with, let's just say you have a patient, stick figure person number 1, who unfortunately has a really bad pneumonia. So they end up on a ventilator. What that means is they have an endotracheal tube, right? It goes into their mouth, down into their trachea, and hopefully sits right in the trachea above the carina, and you have their lungs here. This is a beautiful picture. This is anatomically accurate. Y'all are welcome. And that endotracheal tube is hooked up to a ventilator by tubing, and that ventilator pumps air in and out of that patient's lungs. And the ventilator has a big screen, and this screen is going to be dependent on the brand of ventilator, but a lot of them share similar introductory settings. And for this video, the settings are going to be for volume control or pressure control. We're not going to go into more advanced modes of mechanical ventilation such as SIMV or a PRV or pressure support or what have you. This is going to be for volume control and pressure control, specifically volume control, assist pressure control. So with these types of settings, the ventilator, many of them have 4 options on the bottom of the ventilator. And these 4 options are going to be the basis of this video. And those options are going to be the PEEP, the FiO2, the respiratory rate, and then either the tidal volume or the pressure control above the PEEP. And that's what we're going to talk about today, all 4 of these. So starting with the PEEP. The PEEP stands for positive end expiratory, one too many E's, good for us. Positive end expiratory pressure. So positive end expiratory pressure. Lots of words. And what that is that is a constant pressure that the ventilator is always giving the patient, right? It doesn't matter if it's inspiration or expiration, that is the constant pressure that the patient is always experiencing. All right. If you know anything about scalars, and we've talked about this a handful of times, it's why the pressure scalar doesn't go back down to zero. If this is the pressure over time scalar, and let's just say it's in volume control, you know, each breath looks something like this. It shouldn't be increasing in size, but this is zero, and this line never goes to zero, right? Because this is the PEEP. It's the end expiratory pressure, the pressure that is always there. And most times, the PEEP is going to be somewhere between 5 to 20, and this is millimeters of mercury. And 20 of PEEP is a lot. 5 of PEEP is very minimal. And you can go less than 5, but it's not common. 5 is usually the smallest amount of PEEP that you will set. And the PEEP helps with oxygenation. All right. If someone is hypoxic or they have low oxygen, increasing the PEEP may help them improve their oxygenation. All right, and we'll talk kind of more about that. The FiO2 is the fraction of inspired oxygen, right? FiO2, fraction of, I guess I don't need to do that for every single one, huh? Fraction of inspired oxygen. And this is the percent oxygen that the patient is getting with each breath. And if we think about what this really means, atmospheric oxygen, just what we all breathe in at, I guess, sea level, is 21% oxygen. So on the ventilator, we can set the oxygen anywhere from 21 to 100%, right? Because 21 is just atmospheric oxygen. Many people don't go less than 40%, but you can. There's no reason you can't. I traditionally have not seen anyone go less than 30%, but you theoretically could go all the way down to 21% or atmospheric oxygen. And this also helps with oxygenation, right? If you are hypoxic or have low oxygen levels and you have to go on a ventilator, we can increase the amount of oxygen you're getting with each breath all the way to 100%, right? Up from 21%, which is what you're breathing on room air, all right? The respiratory rate is the number of breaths you're getting per minute. So someone who's just existing out in the world is usually breathing somewhere between 12 to 16 times per minute. But you can set the respiratory rate at whatever you want. We very rarely go less than 8, and even 8 is incredibly low. There's some complex reasons you sometimes will go that low if someone has a very prolonged expiratory phase and breath stacking and all that kind of stuff. We actually covered that in one of the videos up here, auto PEEP, breath stacking, air trapping. So check that out. We'll link it in the video description. And the respiratory rate can go as high, most people don't go above 32. Not to say, you can't, but you probably shouldn't, because again, you start to get breath stacking things. 32 is very, very high. Normal, as we said, NL normal is somewhere about 12 to 16 breaths per minute. So you're controlling how many breaths the patient is getting per minute. The thing about respiratory rate is that most of these modes of ventilation let the patients take breaths to prompt a breath. So the ventilator will kick in and give a breath if the patient is not meeting the respiratory rate that you set. And the respiratory rate helps with ventilation, right? Which is breathing off the carbon dioxide, because that depends on how many times you're breathing per minute, how many times you're blowing off carbon dioxide per minute. All right. And then the tidal volume, tidal volume, is how many cc's or milliliters of this FiO2 you sent that the patient is getting per breath, right? So the tidal volume, normal, most people do it cc's per kilogram of body weight. So normal is going to be 6 to 8 cc's or milliliters per kilogram of ideal body weight. So ideal body weight based on a person's height rather than their actual body weight. So let's just say you set this to, it's really dependent on how tall someone is, but I think for the sake of generalities, 350 to 550 Most people are going to fall within that realm. Some who are super short might be less than that. Some who are super tall might be more than that. But the tidal volume is the cc's or milliliters of air you're getting per breath on the ventilator. And you set the tidal volume only when you're in volume control, and we've talked about this a number of times. So the two main modes of ventilation are volume control and pressure control. In volume control, you're setting a tidal volume. In pressure control, you're setting a pressure above the PEEP, because we said the PEEP is there all the time. Positive and expiratory pressure. It's there no matter what. In pressure control, you set the inspiratory pressure above the PEEP, aka you're telling the ventilator every breath I want you to push this pressure in, and whatever tidal volume that creates is what it creates. So if I set it to 20, what that is meaning is I'm telling the ventilator with every breath I want you just to put 20 millimeters of mercury of pressure into that tube, and whatever pressure that leads to the lungs, whatever volume that leads to the lungs inflating is just what it is, right? And this is usually pressure control above the PEEP. And, there isn't a normal necessarily. You typically don't want to go for both PEEP and pressure control combined, so adding these together above 30, but you can. It's not a law you can. It just might cause some barotrauma and things. So that's pressure control above the PEEP, or the inspiratory pressure is the millimeters of mercury that the ventilator is pushing with each breath. And as we've talked about in different videos, previous videos that you can check out, when they're in a pressure control mode, you're not able to set a tidal volume, right? The four settings would be PEEP, FiO2, respiratory rate, and pressure control above the PEEP. When you're in volume control, you don't set a pressure above the PEEP. You just set the PEEP, FiO2, respiratory rate, and tidal volume, right? So this box here is going to be either tidal volume or pressure control above the PEEP, depending on if you're in a volume control mode or pressure control mode. All right. The mode of ventilation is typically on the ventilator somewhere, often in the top left corner, and it'll say, volume control, pressure control, so maybe VC, maybe PC. And then the top right corner typically will give you a peak pressure, which we can dive into in a future video. But the peak pressure is often, if you're in pressure control, the peak pressure will often be this number. If you're in volume control, the peak pressure will be the pressure created when the ventilator pushes in that tidal volume you set. So again, probably for a future discussion. But these are the five basic settings for all ventilators. We should say, apologies, that the tidal volume also helps with ventilation, right? Because if I'm setting a higher tidal volume, it means there's more cc's of gas exchange going on to help you breathe off carbon dioxide. And you might hear this sometimes, but the respiratory rate times the tidal volume is something called the minute ventilation, or how many cc's of air they get per minute, right? The minute ventilation. So that might be something you all have seen before. Just as a somewhat introductory concept here, mechanical ventilation is obviously someone who has been intubated. They have an endotracheal tube. And intubation is a totally separate discussion, but the reasons for intubation tends to be things like hypoxemia or low oxygen levels, refractory hypercapnia, and we could say refractory hypoxemia too, but refractory hypercapnia or high CO2 levels, inability to protect airway. So airway protection, that patient who is so altered that they're gurgly, they're aspirating, they can't protect their airway. Anticipated clinical course is another one. If someone needs an operation and needs endotracheal intubation and go on a ventilator for their operation, that is another one. And then the other part of airway protection is structural things too. If someone unfortunately had a gunshot wound in the neck and they had an expanding neck hematoma, they might need intubation to keep their airway patent. So these are kind of the four main things. There's a couple other ones, but this is a good way to start. So this is how someone ends up on mechanical ventilation, right? You put the endotracheal tube in and you have to hook them up to the ventilator. When we intubate someone and put them on a ventilator, we have to set a ventilator mode. And this is something you choose, or we choose as a team. And there's a couple different ventilator modes. The two main ones are called volume control and pressure control. And we'll go into these down here, but volume control and pressure control are the two main ones. Pressure control is more kind of front and center in pediatrics, at least that's what we've been told. We don't work in pediatrics anymore. Whereas volume control is often our starting mode in adults. Now, there's certainly exceptions to this. There's some people in adults who still prefer pressure control. In our clinical practice, we tend to choose volume control first, but then sometimes we do end up putting the patient on pressure control for different reasons, and there's lots of complexity here. But just in generalities, for adults, we often start in volume control. Part of that is because a lot of the guidelines or recommendations out there for things like ARDS and what have you are more centered around volume control, although there's definitely a role for things like pressure control too. But instead of us blabbering about volume control and pressure control, why don't we talk about what they are? So volume control, or VC, and this is often called assist control, volume control. The AC, the assist control, is something that's applied to both volume control and pressure control, and just means the ventilator helps determine breaths given. But volume control, the main variable you're setting in volume control is something called the tidal volume. So anytime you put a patient on mechanical ventilation, there's kind of 4 different things that you're setting each time. There's way more than that, but these are the 4 basic things, and it's PEEP, FiO2, respiratory rate, and then either tidal volume or inspiratory pressure. And this is the difference between volume control versus pressure control. So we'll talk more about these in a second, but in volume control, you are setting the tidal volume. Okay, so you are telling the ventilator, you're like, hey, I want this patient to get about 500 cc's of tidal volume with each breath. And the ventilator goes, okay, I'll try to give them about 500 cc's of tidal volume with each breath. This is in comparison to pressure control. In pressure control, instead of the tidal volume, you're setting an inspiratory pressure. You're telling the ventilator, hey, I want you to give about 20 centimeters of water above the PEEP every time you give a breath. And if we think about what this means, if you were in volume control and you're setting the tidal volume, the variable you are not controlling is the pressure that tidal volume creates. The ventilator is essentially just pumping in 500 cc's. It's a little more complex than that, but is essentially pumping in 500 cc's of that breath. And then the pressure that results with in the lungs is not controlled. Right? That just depends on the patient and the pathology they have going on. Whereas in pressure control, you're setting up pressure. So the variable that is not controlled is the tidal volume, because you're telling the ventilator, I just want you to administer this amount of pressure with each breath, and whatever tidal volume that creates will depend on the patient and the pathophysiology they have going on. So if we think about this in a practical sense, we're going to scroll over to the side. In volume control versus in pressure control, what you're going to see is when you set that tidal volume of 500 cc's, there will be kind of an inspiratory pressure, also known as a peak pressure, that'll pop up in the corner of the ventilator screen with each breath. And every time that ventilator pumps in that 500 cc's that you set for the tidal volume, there will be a peak pressure that pops up. That might say 28, it might say 32, it might be really high like 60, and we'll talk more about that in a second. But that variable is not controlled. You are controlling the amount of volume they are getting with each breath, whereas the pressure is just secondary to the amount of volume you're giving them and the patient's pathophysiology. Whereas pressure control, you're setting that pressure, right? You said, let's give them 20 centimeters of water above their PEEP. And then what you're looking at on the ventilator is you will see how much tidal volume this creates. That might create 300 cc's, or maybe 350, or maybe 400. It just depends on the patient and their physiology. But that tidal volume with each breath is going to change, whereas the inspiratory pressure that you set is stable each time. Right? So volume control, the tidal volume is controlled, and the inspiratory pressure it creates, that peak pressure, is uncontrolled. Whereas in pressure control, that inspiratory pressure you're setting, that is controlled, Whereas the tidal volume that creates is uncontrolled. That's going to change with each breath. And that gets into what we have to be careful with, right? So in volume control, you get this consistent minute ventilation. Because minute ventilation, we've talked about this in previous episodes, is the tidal volume times the respiratory rate, right? The minute ventilation is the total ventilation, total cc's breathed in 1 minute. So tidal volume times the respiratory rate, right? If you're breathing 12 times per minute and each breath you're getting 500 cc's, that times the respiratory rate is how many cc's of air you're breathing each minute. Because as we said, the tidal volume, you're setting it, and the respiratory rate, you're setting it. So these are two variables you're controlling. So there's a consistent minute ventilation. But the pressure, as we talked about, is uncontrolled. That peak pressure is dependent on the patient, their physiology, and it might change breath to breath. Whereas in pressure control, you have controlled pressures, because you're saying, I don't want them to get more than this inspiratory pressure, right? I'm setting an inspiratory pressure, and that's the pressure the ventilator is giving them. But the tidal volume is variable, which means the minute ventilation is variable, right? Because you're setting a respiratory rate in pressure control, and you're also setting that inspiratory pressure, but the minute ventilation they're getting is just going to depend on how many cc's of tidal volume that inspiratory pressure gives them with each breath. All right, patient effort for both of these is optional. You're setting a respiratory rate, so patients can breathe over the ventilator. They can prompt their own breaths, but if they don't, the ventilator will give them the respiratory rate that you're setting. It is assist control though, so they could take more breaths. If you set a respiratory rate of 12, but the patient wants to breathe 25 times, that ventilator will give them the assisted breaths all 25 times. All right. Whereas if they are not taking breaths of their own, that ventilator will just give them the 12 breaths that you set. So it's not like the patient is trying to breathe more, but the ventilator isn't helping them with those breaths. The patient will be helped with as many breaths as they take, but at the very least, the ventilator will give them those, whatever respiratory rate you set. This is in comparison to something like pressure support. So pressure support is often kind of what we call a spontaneous breathing trial, or SBT. And this is where the ventilator, all you're setting is kind of this inspiratory pressure to help support them and help them overcome the resistance of the ET tube, right? They have an endotracheal tube going in their mouth down their throat, and there's resistance to that endotracheal tube. It's like trying to breathe out of a straw. So when you put someone on pressure control, all right, pressure support, our apologies. When you put someone on pressure support, the patient has to take their own breaths. Their patient effort is required, right? This is a spontaneous breathing trial. They are taking these breaths, but every time they take a breath, the ventilator will give them a little bit of inspiratory pressure to help them overcome the resistance of that endotracheal tube. And we can set this, right? A lot of times it's 7, or some people use 10. And you could set this really high. You could essentially make this a highly supported ventilator mode, where you can set that inspiratory pressure just as high as you did for pressure control, right? You could set it at 20. But the patient still has to breathe on their own. They still have to prompt those breaths. So we use pressure support during weaning trials because there are no backup breaths. The patient is taking their own breaths, and the ventilator will not give them breaths unless they're apneic and not breathing, in which case the ventilator will alarm, and there's usually kind of a backup apnea rate. The ventilator won't just let them not breathe and, have something horrible happen. But that's like an apnea backup alarm. Otherwise, in pressure support or spontaneous breathing trial, the patient has to take those breaths on their own, but they do get a little inspiratory pressure support. And again, we can set this bedside. SIMV is not used very often anymore. SIMV is essentially a mode of ventilation where patients take their own breaths and also get supported breaths. And it used to be used as kind of this weaning modality where you could try to kind of give them more supported breaths, then you decrease the number of supported breaths they were getting, and if they did okay, it might mean they're able to get off the ventilator, but we don't really do that anymore, and SIMV is not commonly used, so we're not going to talk about it much in this basics lecture. If people are interested in SIMV, let us know, and we could put out a video on SIMV in particular. And then CPAP is very similar to pressure support, so we're going to kind of cross that one out as something we're going to dive into. These three are going to be your 3 main foundational ventilator modes: volume control, pressure control, and a pressure support trial. So we talked a little bit about ventilator settings, just a little bit though. And we mentioned that those ventilator settings include tidal volume, respiratory rate, FiO2, and PEEP. And the caveat to the tidal volume is, again, this would be for volume control, whereas if someone is in pressure control, instead of that tidal volume, you're setting that inspiratory pressure. We'll talk a little bit about ID ratios, but first we want to talk about these 4 different ventilator settings. So when you put someone on a ventilator, we wanted to give you some quote-unquote standard settings that patients often start on. And there are certainly exceptions to this, right? If someone has a COPD exacerbation or someone has a profound metabolic acidosis, there's different starting settings you really want to be cognizant of. But if you're intubating someone and it's kind of a run-of-the-mill intubation, even though that probably shouldn't exist as a phrase, because there shouldn't be anything that's considered a run-of-the-mill intubation, but nonetheless, if their physiology is not profoundly deranged, tidal volume, we often can start them on something like 6 to 8 cc's per kg of ideal body weight. And that's really important. IBW, ideal body weight. And this is not their weight in kilograms. This is based on their height, right? Lungs don't change in size based on our BMI. They're determined based on things like our height. So you can calculate ideal body weight on different calculators online like MD Calc. Some Epic or different electronic medical records have the ideal body weight programmed in there by the BMI. And there's lots of different kind of charts and graphs out there. If we were being honest, we often use MD Calc, but we do not get any kickbacks from MD Calc. That's just what we use clinically bedside. And starting at 6 to 8 cc's per kg is a great starting point. If someone does have acute respiratory distress syndrome, you'll see this kind of 4 to 6 cc's per kg. We got tons of episodes on ARDS out there, so definitely check that out on the channel if you're interested more in ARDS. Okay, the whole point in doing this 6 to 8 cc's per kg is limiting something we call volutrauma. We actually have an episode on ventilator-induced lung injury too, where we talk about volutrauma, but that's just the idea that us giving all this volume to the lungs can cause damage to those alveoli, which can lead to downstream problems. So 6 to 8 cc's per kg of ideal body weight is a good starting point. If you think about a kind of a normal-ish sized human, you can usually get away with 400 to 500, depending on how tall they are, in that 6 to 8 cc's per kg range. All right, respiratory rate, we often start with just normal respiratory rates, something like 12 to 20. You hear 16 a lot, which is reasonable. Remember that the tidal volume times the respiratory rate does determine your minute ventilation. So if you have someone who's in profound metabolic acidosis, their pH is very low, and you know that what they're doing is that they're just breathing like mad to try to breathe off extra carbon dioxide, right? Try to have a respiratory compensation for their metabolic acidosis. I guess we're just full of plugs today, but we got a whole series on acid-base status too. If you're interested, check it out. But yeah, if someone has a profound metabolic acidosis, and goodness forbid you have to put them on a ventilator, just be really careful. They might need a much higher minute ventilation. You might need to crank up this respiratory rate. This can go as high as 30, 32. It depends a lot on the patient's physiology. Some patients, this is way too high. Some patients do okay with it. But yes, 12 to 20, normal starting rate-ish. 16 is a fair place to start. You can go much higher than that, assuming they tolerate it, and just be really cognizant of patients' kind of pathophysiology going on, because some patients need a much higher respiratory rate to start to help compensate for things like metabolic acidosis. Some patients need a lower respiratory rate. If they have something like COPD, they're high risk for breath stacking or auto PEEP, which is something we have talked about in the channel previous, and we're actually going to come out with a video on mechanical ventilation obstructive lung disease, so stay tuned for that if you're more curious. FiO2 is the fraction of inspired oxygen. Okay, this is essentially how much oxygen you are giving them in their breathing tube. The range can go from 21% to 100%. Why is 21% the lowest? Drum roll, that is the FiO2, just in the atmosphere at room air. That's what we are breathing right now. So we don't tend to go lower than 21%, because that would be lower than the physiologically present oxygen just in the atmosphere that you're breathing every day. When we put patients on the ventilator, oftentimes they'll get started just on 100% FiO2, and you could rapidly titrate it down, target that SpO2 greater than 92%. Some people put this at 88% if people have a lot of chronic lung disease, PaO2 greater than 60. There are different targets for things like ARDS or post-cardiac arrest. Sometimes you want this PaO2 a little bit higher, but yes, good place to start. So these patients often start on FiO2 of 100%, and then you can rapidly titrate it down after you get them intubated. And then PEEP, this is the positive end expiratory pressure, PEEP, positive end expiratory pressure. And the way to think about this is essentially the pressure that the ventilator is giving the patient at all times. It does not vary. When they breathe in, it's there. When they breathe out, it's there. It is the end expiratory pressure because it's the pressure that's still there at the end of expiration, but it's also there all the time. It doesn't go anywhere, okay? The reason for that, if you think about the lungs, they have all these alveoli, all these little kind of balloons. So this is kind of a bronchial, and they go into all these really thin-walled alveoli, and these thin-walled alveoli can collapse really easily. When they collapse, they get all full of gunk and they can't exchange gas. So PEEP helps stent open these small alveoli, right? This pressure that's present all the time helps keep these alveoli not collapse down. It does other stuff too, but that's one of the main reasons. So we almost never go to 0 PEEP. Really, the lowest PEEP you'll see is 5. Now, 0 PEEP, some people call it ZEEP. There are some things you can think about for using ZEEP. We don't tend to use ZEEP, but some people do for different things, like pneumothoraces or what have you. But yeah, we don't tend to go below 5 of PEEP. When you're intubating someone and putting them on a ventilator, starting at 5 of PEEP is reasonable for someone who's got normal lungs. If someone's got, pulmonary edema from heart failure, they got a really bad pneumonia, sometimes starting a patient on 8 of PEEP or 10 of PEEP right off the bat is reasonable as well. And then this is something you'll titrate based on their ventilator mechanics, okay? PEEP and FiO2 increase oxygenation. So FiO2 and PEEP, they increase oxygenation, whereas tidal volume and respiratory rate help manage and improve carbon dioxide. So if someone is hypoxemic, their O2 is low, you want to either increase their FiO2 or increase their PEEP. If someone's carbon dioxide is high, you either want to increase their respiratory rate or increase their tidal volume. Okay, so tidal volume, respiratory rate for carbon dioxide, FiO2 and PEEP for oxygen. And then I to E ratio is on here. This is a little bit of a more advanced topic. So this is the inspiratory to expiratory time. And the thing to remember here is when we're setting the ventilator, we set a respiratory rate. And that respiratory rate is how many breaths the ventilator is going to mandate within 1 minute or 60 seconds. So if I set a respiratory rate of 20, that's 20 breaths over 60 seconds, which means the ventilator has about 3 seconds to give each breath. And it doesn't, it doesn't work out perfect that way. But the I to E is how much of this respiratory cycle the ventilator gives for the inspiratory phase compared to the expiratory phase. So if it's 1 to 2, right, and you have 3 seconds per breath, that means there's going to be 1 second for inspiration and 2 seconds for expiration. And that's pretty normal. If anyone can just think of their own breathing pattern as you're sitting there right now, you expire, you exhale for longer than you inhale. So an I to E ratio of 1 to 2 is about normal. Where this becomes more significant is things like obstructive lung disease, COPD, asthma, where you have this prolonged expiratory phase. And sometimes you have to make this I to E ratio 1 to 4, sometimes even 1 to 5, to try to give them much more time in the expiratory phase to breathe out. But just the things to remember with I to E ratio is that your respiratory rate is how many breaths over 60 seconds, which then means you only have so many seconds per breath, and the I to E is how much of that time per breath you're giving the patient to inhale as compared to how much time you're giving them to exhale. All right, and as we mentioned here, longer expiratory time and obstructive lung disease. So those are the basic ventilator settings. Hopefully that made sense. Now going into key pressures and parameters. This is getting a little bit more advanced, but we're creeping towards it, so hopefully everyone's still with me. And the terms we're going to talk here is the peak pressure, plateau pressure, driving pressure, and auto PEEP. And we actually have individual episodes on each one of these, so again, check out that mechanical ventilation playlist or our podcast page or YouTube page or what have you. But the peak pressure, okay, the peak pressure is the pressure that the ventilator feels when it's pumping in a breath. So that's during inspiration. The ventilator pushes air through the circuit, through the endotracheal tube, into the lungs, right? The trachea, the bronchi, the bronchioles into the alveoli. And it's the pressure the ventilator feels while it's trying to do that. So this is often secondary to airway resistance and lung compliance together, okay? Because if you could imagine, When we push your breath in, you have to overcome airway resistance, and then you also have to start to distend those alveoli, so you got to overcome some lung compliance. And there's a real simplistic way to think about it, but it is reasonable. So when you are thinking about inspiratory pressures, what's normal and what isn't is tough to say. If it's less than 40, I feel pretty okay about it. If it's starting to get more than 40, I start to get worried unless there's some physiology there that makes sense. And this is in centimeters of water. So those peak pressures are airways resistance and compliance, and you kind of look for that 40 number, although that's not hard and true. We have a whole episode on peak and plateau pressure, so we're not going to dive into the causes of each because that's even more advanced. We just wanted to point out that they exist and talk about some norms. Plateau pressures are driven from an inspiratory hold. So the ventilator pushes a breath in, and then it pauses, and there's no flow. The breath's just sitting in the lungs. So there's no longer air moving past the airways. So it doesn't look at airway resistance because there's no air moving past those airways. This is really looking more at, lung compliance. Again, simplistic view, but reasonable for an introductory lecture, because what pressure is there is how much those alveoli and chest wall is trying to kind of push down, and that is a means of kind of lung compliance and chest wall mechanics. Okay, this is not, so peak pressures show up every breath on the ventilator, well, at least most ventilators. When the breath gets pushed in, if you're in volume control, you'll see kind of this little peak pressure pop up, sometimes in the top right corner, sometimes elsewhere, depending on the ventilator brand. Whereas plateau pressures, you have to physically do a maneuver on the ventilator called an inspiratory hold. And you really want those plateau pressures to be less than 30 to avoid barotrauma. Again, talk more about that in the ventilator-induced lung injury episode. Driving pressures, we put it in here, and in retrospect, is probably a little too advanced for a basics lecture. But the calculation here is plateau pressure minus PEEP, and it is a surrogate for kind of optimal alveolar distension. And we'll put out a specific video on driving pressure, so we won't spend too much time here, but just know it exists, and it's something that people might talk about on rounds. And then auto PEEP is also important to know it exists. This is air trapping, so auto PEEP, also known as air trap, also known as breath stack. We have a whole episode on this, linked again in that playlist. And this is more common in obstructive lung diseases like COPD. And the reason this happens is the ventilator is pushing that air in, that breath in. But unless you give the patient enough time to exhale that breath fully, the ventilator will just give them another breath when it's time. So let's just say if I had a tidal volume that I set at 500 cc's, and that patient got that full 500 cc's, but while they were slowly breathing out, they only got 450 cc's exhaled before the ventilator said, oh, time to give you another breath. And it gives then another 500 cc's. Well, they only exhaled 450 of that original 500, so they still had 50 cc's of air in their lungs that they had not exhaled yet. Now they got another 500 cc's. So total now they have 550 cc's in their lungs. They're trying to breathe that air out, and again, they only got out 450 cc's. And then the ventilator says, oh, time to give you another 500. Well, now they actually have 100 cc's left over, plus that new 500. Now up to 600 cc's. See how those breaths are stacking? And over time, that creates higher pressures in the lungs because those lungs are just getting full of air. They're not exhaling it. And it can be really, really dangerous. It could even be deadly. So auto PEEP or breath stacking, something to think about. Again, we won't dive deeper in this episode, but definitely check out those other episodes or let us know if you have questions. And then last but not least is going to be common ventilator alarms. The three to think about are high pressure, low pressure, and high respiratory rate. Again, these are kind of the basal, foundational, fundamental alarms. There's tons more, which we talk about in a future video. But high pressure alarm is essentially related to that peak pressure. And the ventilator is saying, hey, every time I'm trying to push this breath in, it is creating so much pressure, such a high pressure, I'm worried. And there's a quick checklist you can think of, right? One is something kinked, okay? So is the tube kinked? Is the tubing kinked? Is the patient biting on it? Is there a big kind of clog in the tube? Because all that can lead to high pressure. So always run your circuit, make sure there's no kinked tube. After that, bronchospasm can do it if those airways are spasming and closing down. So think about, has the patient got obstructive lung disease like COPD? Do they need a breathing treatment? Do they have a bronchospasm from some medication they were given? That can do it. Certainly ventilator desynchrony, things like coughing or anything where that patient's kind of pushing against the breath that's being delivered, can lead to high pressure alarms. And then just decreased lung compliance can do it too. That would be both a high peak and a high plateau pressure. But the easily reversible things are, is the tube kinked or is it clogged? Do they have bronchospasm? Is there ventilator desynchrony going on? And if that's not the case, you get worried about kind of some inherent lung pathology leading to decreased lung compliance. Low pressure alarms are hopefully easier to deal with because this is almost always a manifestation of something wrong with the circuit. Okay, so run your circuit. Is there disconnection? Did something pop off where the tubing's no longer connected to the endotracheal tube? Did they bite through the endotracheal tube where there's a hole in it now? Is the cuff ruptured? Right, these endotracheal tubes, most you probably know, are a literal tube, little bevel at the bottom, and then they have a balloon, a cuff that you inflate. And they go in the patient's trachea. So this cuff has to be inflated so it's touching the walls of the trachea so that air can't move past, in or out of the trachea unless it goes through the endotracheal tube. But if that cuff is ruptured, they'll just lose all the volume that you pumped in through the ET tube and it'll just come right back out around the tube. So is there a cuff leak? And you can usually hear the patient, speaking or gurgling or making vocalizations because they're able to pass air through their vocal cords. Whereas if the cuff's fully inflated, they can't pass air through their vocal cords, so you shouldn't be able to hear them. Or is there a circuit failure, right? Is the circuit itself have some kind of issue? And then a high respiratory rate, that'll be an alarm you sometimes see, and that's usually related to the patient, pain, anxiety, inadequate sedation. But sometimes it can be from physiologic things like profound metabolic acidosis, where they're trying to ramp up their tidal volume and minute ventilation and all that jazz. Really high pressure and low pressure basics are these here. Always run the circuit. If there's one thing to take away, it's always run the circuit. All right, make sure everything's connected, make sure nothing's bitten, kinked, disconnected, fallen off, clogged. And after that, it's a little easier to then think about the patient itself with what physiology could be going on leading to these things.
All right, thanks for sticking around. So starting with waveforms, there's three basic waveforms that the ventilator gives us. There's the pressure time waveform, so pressure is the P. There's the flow time waveform, so flow is this V with the circle over it, and then there's the volume time waveform. All right, so these are the three main waveforms the ventilator gives us when looking at it, or that we can find on the ventilator: pressure, flow, and volume. And they show us different things. All right, the first thing to notice and to know is that the waveforms will actually look different depending on if the patient is on volume control ventilation versus pressure control ventilation. And we'll go into how those differ in terms of the waveforms. But volume control ventilation, for those of you that don't know, essentially means you set a tidal volume. All right, so you set the tidal volume, and the pressure then is the variable that will change based on the tidal volume you set. Whereas pressure control is you set the pressure, and then the tidal volume is the variable that will change based on the pressure you set. So, you're controlling the volume in volume control, and you're controlling the pressure in pressure control. But as such, the waveforms, pressure, flow, and volume waveforms will look different. So what we have drawn down here are these waveforms if the patient is on volume control. So they're set to volume control. You chose a certain tidal volume to give them, say 450 cc's of tidal volume that is set so that they get that each breath. You'll set their respiratory rate, say 16, and then you'll set their PEEP, their end expiratory pressure, and we'll say you set their PEEP at 5. The other thing you set is their FiO2, their fraction of inspired oxygen, and we'll just say 50% for this case. Not many of these numbers are relevant for this discussion, except for the PEEP, and then just knowing that they're on volume control, and we'll get into why. So starting first, we have our pressure versus time waveform. And this is a single breath, right? So that's how you can think of this. This is a single breath that the ventilator has given the patient. So if we're thinking about this, it's how the pressure changes in the circuit, the ventilator circuit, with that breath. So the things we have are, let's see if we can draw, probably not, there's a patient, right? A stick figure patient, they're lying down, here's their arms lying at their side, here's their head, here's their mouth, eyes, and they have an endotracheal tube in their mouth, right, hooked up to the ventilator machine, right? And the ventilator machine has our waveform stuff, but the ventilator is pumping volume into the endotracheal tube that then goes into their two lungs. And the pressure in this closed circuit, right, lungs, trachea, endotracheal tube is what's being shown here. Notice that this is zero pressure, and the pressure waveform does not start at zero. And that is because of the PEEP. What you have set is a end expiratory pressure, and that is the PEEP. The PEEP is where this pressure waveform starts because the PEEP is the pressure in this circuit all the time. Whether they're breathing in or breathing out, the PEEP is always there. And that's what the start of this pressure waveform is showing, the PEEP here. So you have your PEEP, and then the pressure starts to increase. This is when the breath is going in, right? So this is inspiration. And on the pressure waveform, you might see two different things. You might see this, which is just a smooth transition to increasing pressure. And if it looks like this, it means the ventilator gave the breath. The alternate option, which maybe will be easier to understand, is if there's a little dip here, a little decrease in pressure, this right here is suggestive that the patient took a breath, right? Because the patient contracted their diaphragms and created a slight negative inspiratory pressure, so the pressure dropped just for a second, and then the ventilator noticed this, and then the ventilator gave them their volume-controlled breath. And this is what the waveform will look like. It increases, increases, increases to a point, and this top pressure here is going to be known as the PIP, or the peak inspiratory pressure, the highest pressure that is seen in the circuit when that volume is given. And the peak inspiratory pressure is usually a surrogate for kind of airway resistance, because it's the pressure that is seen in this circuit when they're pushing the breath in. So if you have a lot of bronchoconstriction, or the ET tube's got a clog, or there's a lot of mucus, there's more resistance when you push that breath in, so this PIP, this peak inspiratory pressure, might be higher. Then what happens after you get to the kind of this maximal peak inspiratory pressure is the pressure in the circuit drops. And you won't always see this plateau here. I put this plateau here just to demonstrate that this would actually be known as the plateau pressure. But this is something that needs to be measured. You have to do a plateau pressure. And a plateau pressure is after the breath is pushed fully in, so picture the ventilator pushing that breath in, you then pause at that maximal amount of tidal volume. And the plateau pressure is this plateau that you'll see, which is representative primarily of the compliance of the lungs. Some other things contribute as well, such as how heavy the chest wall is and those types of things, which is out of the kind of indications of this video discussion, but this would be the plateau pressure. Note though, unless you're testing for the plateau pressure, you won't see this here, right? Essentially this waveform instead will just come like smoothly down. It'll come to a peak and then start to come down. All right, you won't see this plateau that you would see if you were testing the plateau pressure as we drew out here. All right, so then the pressure decreases until you get back to not zero, but to that end expiratory pressure you set, which is PEEP, and we said a PEEP is 5. So this right here would be a pressure of 5 millimeters of mercury. All right, and that is under volume control during a single breath. If it is under pressure control, right, so we said this is in volume control. We're just going to draw right here quick. If it were pressure control, just the shape of the curve looks a little different, because if there's a smooth pressure, so you're setting the pressure, it'll look more boxy, right? So it'll look like that, although I apparently am a little slanted. That was unintentional. But it'll just go straight up like this and come down. And this would be under pressure control settings. So again, you still have your PEEP here. The peak inspiratory pressure, the PIP that we talked about up here, is going to be the pressure that you set for pressure control, which will correlate to here. If I set their pressure control for, I don't know, choose whatever you want, 20, this PIP will be 20. And that is what I set on the ventilator because I'm controlling the pressure. It doesn't go higher than I set it. And then it will smoothly come back down. So that's what it would look like under pressure control. It'd be much boxier. All right. In a future video, we're going to talk about how these morphologies change with different kind of pathophysiologic responses, whether it be flow hunger or breath stacking or ineffective triggering or flow starvation. So look for a future video on that. This is just the introduction. Next waveform we have is flow. That's what this V with the circle over it, it's flow. So this is flow by time. It's a flow time waveform. Again, under volume control. So what we see here is a box. So you start at 0, right? You start at 0 flow. It's not like pressure where there's a PEEP already set. There's no flow baseline. And then what you get is you get inspiration. That's what is on top here. You get inspiration. I guess I'll just write inspiration here. And that's that flow shooting way up to help the patient inspire. It's flowing in that volume that you set. All right? And this here, understandably so, is the peak flow. And the peak flow is actually not a surrogate, but a result of your inspiratory time. Your inspiratory time, also known as your I time. This makes sense, right? Because what I said on the ventilator is a volume. I said each breath I want them to get about 400 cc's. So how much flow there needs to be to give them 400 cc's depends on how fast I set that breath to go in, right? If I set that breath to go in over 1 second, it would have to flow that volume in differently than if I set that breath to go in over 2 seconds, because it would have twice the time to push in that 400 cc's of volume. So the peak flow here is related to the I time, the inspiratory time, which is something you set on the ventilator, if that makes sense. Hopefully it does. This bottom part here is expiration, right? So negative flow, they're expiring back at the ventilator. And it should always return to 0 here, right? It starts at 0 and it returns to 0. Again, we're going to go into abnormalities at another time, but something you sometimes see is if this does not go back to 0. We're just going to erase that. We'll put the line back in. But let's just say it doesn't go back to 0 and then it starts another inspiratory breath. See how you're not at 0 yet? This can sometimes be suggestive of things like air trapping. Again, look for that video. We're going to be putting it out hopefully in the next week or so on how these waveforms change depending on different possible pathologies going on. So this is in volume control. We'll draw again. If it were to be pressure control, the waveform looks a little bit different. All right, you get this increase as we did, but instead of that boxiness, you get a decrease that's slanted and then your expiratory breath. So instead of this box for pressure control, you get more of a triangle shape rather than that box shape, which is just related to how the flow will work in pressure control versus volume control. All right, last but not least for the waveforms is volume versus time waveform. And this waveform looks pretty obvious, right? The volume will increase during inspiration, so this left side is inspiration, and then the volume decreases during expiration. So that's pretty straightforward, right? In the future video, when we talk about different things that could go wrong, we'll talk about things like, again, air trapping, volume goes up in inspiration but doesn't return to 0 in expiration, or things like breath stacking, volume goes up, comes down, but then they take another breath really quickly, some of those types of things. So this is the introduction to the waveforms in volume control with some shout outs to the pressure control changes, different parts of the waveform, what they mean, and future video, which we'll end up putting in this video's description once it comes out. We'll go into the pathology that can happen and then clinically what you should change. Now let's talk about loops. We have two main loops we're going to talk about. The first is the pressure volume loop, pressure on the x-axis, volume on the y-axis. And this is what a pressure volume loop tends to look like on the ventilator. it does not start at a pressure of 0, right? But it does start at a volume of 0. The pressure it starts at, again, is going to be the PEEP, because there's pressure in that circuit all the time, no matter what. And then what we have here is, if we were to split this down the middle, we have the inspiratory limb, so you're inspiring here, and then the expiratory limb, you're expiring here, which makes sense, hopefully. The different parts of this loop, things that they talk about that are important to know, are the inflection points. So if we were to draw this and just make it maybe a touch more obvious, the inflection point, what we would draw is something like this. Very kind of flat out, and then an abrupt change where it starts to go up. And this would be the lower inflection point, LIP, lower inflection point. And what we can see happening here is the pressure is increasing with very little volume increase up until this point, right? And the thought with the lower inflection points are, this is where compliance changes. So this lower inflection point is the pressure it requires to open up the alveoli. And in a perfect world, the lower inflection point would be equivalent to the PEEP you have set, because you don't want these alveoli, right? The alveoli are kind of these grape structures where air exchange happens. You don't want them to collapse and then have to be opened and then they collapse, and opened and then they collapsed, because that can cause something called atelectatrauma, which is bad for the lungs. And we don't want atelectatrauma. But this lower inflection point is when the pressure has to ramp up before the volume starts to change. And again, in a perfect world, it would be kind of equivalent to your PEEP, because that is where the alveoli are kind of perfectly distended, not over distended, not under distended. The lower inflection point is the pressure where the kind of PEEP is just right for those alveoli to stay open. Then there's an upper inflection point. And the upper inflection point is where the curve of this waveform starts to change. And the upper inflection point would be when there's, we'll again make it more obvious. So excuse us, it's not going to connect, but that's okay. So the upper inflection point could look like this. It is where, again, the pressure starts to increase a lot and the volume does not increase. And this is known as the upper inflection point. And this is when the alveoli start to get over distended, meaning they are too open. Alveoli are a bunch of grapes. You can get alveoli that are under distended, and that can cause atelectatrauma, as we talked about. You can get alveoli that are kind of porges just right, or you can get alveoli that are over distended. Right, they're way dilated, they're very over distended. And the upper inflection point tells you the pressure when they're over distended, right? Because the pressure starts to increase a ton, right, this way, with very little increase in the volume that is given. And if it gets bad, they call it a bird's beak. And you don't want the bird's beak. It means that your pressures or your volume are set too high, because you're starting to get over distension of the alveoli. So what you want it to look like is similar to how I drew it the first time, if I can replicate that drawing, let's see, which is where you don't really have much of an inflection point, and it goes back down into expiration. All right. And again, we're going to get into this more in that future video about the pathology, but let's just draw this here. If you start to get loops that look like they're lying flatter, sometimes that means that there's a decrease in compliance, right? Because there needs to be bigger pressure changes, P on the x-axis, with smaller volume changes. Whereas contrarily, if you get loops that are sitting upright more, again, those are smaller pressure changes with larger volume changes, so that could be improvement in compliance. All right, so when it lies flat like that, this is actually better compliance, positive compliance, better compliance, and this is worse or actually it's in green, but you get what I mean, worse compliance. And we'll talk more about that in the future video. The last loop we're going to talk about is here. It's the flow volume loop. Let me erase some of this just because it gets in the way. Oh, I erased the F for flow. So the other one over here is the flow volume loop. All right, and the flow volume loop, I don't look at it as much. Maybe I should. I guess I'm guilty of that. But the flow volume loop here is inspiration on the top, positive flow, expiration on the bottom. And you want it to have this nice, smooth contour. There's not much to say about this loop until we talk about pathology, but a few things that you might notice with the flow volume loop would be something like sawtooth pattern, all right, or the scoop pattern, which is kind of scooped. And these mean different things, whether it's obstruction or mucus or what have you. And again, look for that future video for that. But the flow volume loop, you want it to follow this nice inspiratory, expiratory contour on the ventilator when you look at that loop.
So today we're going to be talking about assist control pressure control, also known as ACPC or assist pressure control, or many people in the clinic are going to just refer to it as pressure control, and that's what we're going to refer to it as for the rest of this video. And we're going to talk about it in relation to the pressure time scaler, the flow time scaler, and the volume time scaler. Before we do that though, we wanted to talk a little bit about pressure control. So on a ventilator, there's lots of different things you can set, but the main 4 things that you can set are the PEEP, or the positive end expiratory pressure, the FiO2, or the fraction of inspired oxygen, the respiratory rate, and these 3, we have done this exact same video for volume control. Again, we'll link it in the video description. These 3 are all present in both pressure control and volume control, right? Volume control being you control the volume, and the uncontrolled variable is the pressure, whereas pressure control, you control the pressure, and the uncontrolled variable is the volume. And we'll talk more about this in a second. But in both of these modes of ventilation, these 3 settings are the same: the PEEP, the FiO2, and the respiratory rate. The setting that is different between the 2 is the 4th. And in pressure control, you're setting the inspiratory pressure, whereas in volume control, you're setting the tidal volume, or the cc's of air that is being pushed into the lungs with each breath. So this is volume control. In pressure control, you're setting the inspiratory pressure. And what you're saying, what you're telling the ventilator is you're saying, listen, with every breath, I want you to give this pressure, right, this millimeters of mercury. And that pressure is going to create a tidal volume. The tidal volume is the cc's, or milliliters of air the patient gets with each breath. That's the tidal volume. So the inspiratory pressure you're setting is going to create a tidal volume, but the tidal volume created is going to be very patient dependent, right? It's going to be based on the patient's anatomy, physiology, their lung compliance, all these different things. So this is the uncontrolled variable. This is the result of the inspiratory pressure you set. The nice thing about pressure control, though, is that the ventilator, it won't go above this inspiratory pressure, usually. So if you're worried about, barotrauma or certain damages from high inspiratory pressures in volume control, because in volume control, you're setting the volume here, and the pressure that results from that volume is uncontrolled. You're saying, I want the patient to get 500 cc's per breath of tidal volume, and whatever pressure that takes is what that pressure takes. In pressure control, you're saying, I want the patient's lungs to just get this pressure, and whatever tidal volume that pressure creates is the amount of tidal volume they'll get with each breath. All right, so the tidal volume is a result of the inspiratory pressure you set. So there's nothing in here where you're setting a tidal volume. You're setting an inspiratory pressure, and whatever volume results from that with each breath is the volume that results with each breath. And you can go, let's say they're getting too much tidal volume, you set the inspiratory pressure at 30 millimeters of mercury, and it's resulting in a tidal volume of 700 cc's per breath, and you're like, that's way too high. Well, you can go down, right? Maybe you'll decrease the inspiratory pressure to 20 millimeters of mercury. And that pressure being lower, you could picture, right? If you're pushing in less pressure, the tidal volume is going to be lower. Maybe the patient then gets 500 cc's per breath. And most of the time, and this is ventilator dependent, most of the time this is the pressure above the PEEP. So let's say I set this at 15 and the PEEP is at 5. That means the total pressure they're getting with each breath is 20, 15 plus 5. Again, a little ventilator dependent. Okay, so you're setting an inspiratory pressure in pressure control. You're controlling the pressure. How do we understand that with the scalars? Well, the scalars look different in pressure control than they do in volume control, or a different mode of mechanical ventilation. And that is based on three different things, right? Anytime we're thinking about a mode of mechanical ventilation, a way we can help to understand it is based off of what the ventilator does with each breath. And what creates a breath? Well, for the ventilator to create a breath, there has to be something that triggers the ventilator to give a breath, right? So that's how the ventilator decides it needs to start a breath, because this is a machine. It's not thinking for itself. You need something that triggers the ventilator to give a breath. You also need the ventilator to target something, right? It can't just push in air randomly, right? It has to target something. And then you need the ventilator to cycle or to end the breath, right? And all these are things that the ventilator isn't thinking about. It's not, you need to set this. And in pressure control, these three things differ than volume control. So in pressure control, the thing that triggers a pressure is the time. And this is actually the same as volume control. So you set a respiratory rate at 20, and the patient can take breaths that count towards that 20. But let's say the patient isn't taking any breaths. 20 breaths per minute, that means one breath every 3 seconds. And if the patient doesn't breathe in 3 seconds, that triggers the patient or the ventilator to give the patient a breath. So time is the trigger. Every 3 seconds, that patient should get a breath, because I set the respiratory rate to 20 breaths per minute. And in pressure control, the target is the pressure you're setting. So you're setting a pressure, again, let's say it's 20, and you're telling the ventilator that you want them to give 20 millimeters of mercury with each breath, and that's what the ventilator is going to target. It's going to target 20 millimeters of mercury. All right, so then how does it cycle? How does it end the breath? Well, time as well. Because each breath, and this is a more advanced setting, but each breath only lasts a certain amount of time, right? So let's just say, I'm just making this up for the sake of easy numbers, but let's say that you said the breath can last for 2 seconds, right? The ventilator will cycle or end that breath at that 2 seconds that you set it. And ventilators are smart. They let the patient also contribute to some of these things if the patient wants a longer breath or a shorter breath, but not to too much, because this is ventilator desynchrony, which we talked about in some of these other videos that we'll link in the video description. It can cause ventilator desynchrony or the patient not cooperating with the ventilator. But in pressure control, the target is what you set, right? It's going to target a certain inspiratory pressure. So if we think about the scalars then, if we go down to the scalars, this is the pressure on the y-axis versus time scalar. This is 0 pressure, and then this is all time. This is the flow versus time scalar. This is 0 flow. And this is the volume versus time scalar, and this is 0 volume. The volume versus time scalar is very similar for all intents and purposes. It's pretty much the same. It has the same look between volume control and pressure control. All right, it looks the same. And what it is this is a single breath. Every triangle is one breath. And what happens in this breath is the volume goes up, right? It's positive. This is inspiration, or this is when the ventilator is giving a breath. And you get to whatever you set, right? 400 cc's, 500 cc's the tidal volume, and then the volume starts to go down. That's when the patient is expiring or breathing that air out, right? And this is going to be your whole breath, your tidal volume, 400 cc's. They inspire to 400 cc's and then they breathe it out. And it should go back to 0 after each breath, because you are expiring the same amount of tidal volume that you inspired. And if this doesn't happen, you can get breath stacking and some of these other things. We actually made a video on it. We'll link it in the video description. Auto PEEP, breath stacking, air trapping, where we talk about what happens when you're not expiring all the air each time. Yeah, and that's each breath, right? This is breath 1, breath 2, breath 3. You inspire, right? Ventilator gives the breath, then you expire or breathe out all that air. It goes back to 0, and this is your tidal volume, or how many cc's of air you're getting with each breath. Same thing, inspiration, expiration. And these, again, look the same between volume control and pressure control. The pressure and flow scalars look different between the two, though. And this is what pressure control looks like, and it's all about the target, right? In pressure control, you're targeting a pressure. So you get this flat top because you're saying, I want it to be 20. Right? So the ventilator says, great, this here, 20. So the ventilator cranks up the pressure with each breath to 20, and it just leaves the pressure at 20. So you get this flat top, and that's just sitting at an inspiratory pressure of 20. Then when the breath's done, it drops back to not quite 0 here, because this is the PEEP, which we talked about in that other video that we mentioned, the introduction. So we won't go into it here as much. But every breath, right? So that's breath 1. Breath 2, it goes straight back up to that inspiratory pressure of 20 you set. It leaves it there for the whole breath, and then it drops back down to the PEEP. That's breath 2. Same thing for breath 3. And that's why you get this flat top, because it's a constant pressure that you set, right? You're like, I want this pressure to be 20 millimeters of mercury for the whole breath. That's what the ventilator targets, and that's what it keeps it at for the duration of the breath. There's no in between, it doesn't ramp up and ramp down. It just goes straight up to 20 because that's what you set. It stays at 20 for the breath. When the breath's done, it goes back down, right? Breath starts again, straight up to 20, stays at 20 for the whole breath, back down. The flow that results from that looks different in pressure control than volume control as well, right? The flow here is going to be dependent on how that pressure was given, right? So the pressure just ramps up to the pressure of 20. So flow starts at 0, right? This is when there's no breath being delivered. There's no inspiration or expiration going on. And all of a sudden the ventilator gives the 20 millimeters of mercury and the flow goes way up, right? And then it stays at 20. So if you picture what this looks like, because the pressure doesn't slowly ramp up. The pressure just goes to 20 and keeps it there. So that initial up to 20 creates this steep upslope for flow. And then as it holds it at 20, the flow actually starts to slowly decrease. It's still positive. You're still getting flow into the lungs, but it starts to decrease up until that breath is done, right? So this here lines up with when the breath ends. So at this point, there's no more inspiratory pressure being given. So it drops down to negative flow because the patient starts to breathe out. So this here is inspiration. This here is expiration because the patient is breathing that air out. So there's negative flow, inspiration, and then I'm blowing out expiration. So there's negative flow up until the breath is over. And then there's 0 flow because there's no inspiration or expiration. And same thing, the pressure starts, it gives a pressure to 20, so the flow shoots up quick. The pressure then stays at 20. So you're still getting a breath in, but it's not, you initially get and then you start to keep that pressure constant. So the flow slowly decreases while it's still going in until the breath is done. And then you start to expire. Right? So inspiration, expiration, expiration. And that's why you get this triangle flow for pressure control, because you're getting this set pressure that's cranking up to the pressure you want, and then it's staying there, right? That's the pressure scalar staying there. And as it stays there, you don't get this huge increase. The flow's still positive, but it's kind of ramping down until that pressure's done. All right, so this is characteristic of pressure control. You get the flat pressure top because that's what's targeted, and the flow does this huge increase and then slopes back down towards 0. All right, thanks for sticking around. So assist control volume controller, or ACVC, or assist volume control, AVC, or simply volume control. And this is what it's often referred to in the clinical arena, and that's what we're going to use for the rest of the video, is just call it volume control, although we're talking about assist control, volume control. And we're going to use scalars to understand this. But before we dive into that, we wanted to just talk about volume control, what that meant. So this is a mode of ventilation. When you intubate someone and put them on a ventilator, you can select the mode, the way in which the ventilator is delivering that patient's ventilation. And when we talk about modes of ventilation, for most modes, and most primarily being the two we use most often, volume control and pressure control. Volume control, which we're talking about in this video, and as the name implies, is where you control the volume. Makes sense. Pressure control is where you control the pressure. So in these two different modes of ventilation, the difference in what you set is in volume control, you set a tidal volume, and in pressure control, you set an inspiratory pressure. And what this means is the thing you're not setting in that mode is the uncontrolled variable. So in volume control, you're controlling the tidal volume the patient is getting with each breath, or the cc's of oxygen that the ventilator is pushing into the lungs with each breath. That's the tidal volume. But what you're not controlling, the uncontrolled variable that results from this, is the pressure, the inspiratory pressure, the peak pressure in this case. In pressure control, you're controlling the pressure. You're saying, hey, ventilator, with each breath, I want you to give a set pressure. What is uncontrolled, though, is then the tidal volume, and we'll put uncontrolled for these, because that's the uncontrolled variable that results from the pressure you set. So what this means is there's kind of 4 main settings on a ventilator. There's certainly many more, lots of complexity there. But the 4 main settings, 3 are shared between these 2 modes of ventilation, and that is PEEP, or the positive end expiratory pressure, that is the FiO2, or the fraction of inspired oxygen, and that is the respiratory rate, or how many breaths per minute the ventilator is delivering. And these 3 are on both volume control ventilation and pressure control ventilation, and you're choosing these. You're saying, I want a PEEP of 5, an FiO2 of 60%, a respiratory rate of 20, or whatever you choose. And we're not going to be talking about each one of these in this video, although we certainly will in a future video, so definitely subscribe and stick around for that. The 4th setting on the ventilator is what's going to be different between volume control and pressure control. And for the sake of this video, again, we're going to do a video on pressure control, but this video we're talking about volume control. So what you're setting here is the tidal volume. And the tidal volume is the cc's, or milliliters, of air that the ventilator is going to deliver per breath. So if you're in the clinical arena and you're setting a tidal volume, it might be, I want the patient to get 400 cc's per breath, 400 cc's of air, or 500, or 350, or what have you. And that is volume control ventilation. What makes it different? Many things. But in the settings, what makes it different from pressure control is that you're setting a tidal volume that you want the patient to get with each breath. Now, ventilators are smart. There's lots of algorithms these days. Let us mute that. And the ventilator is not just going to give this tidal volume every time. The patient has some control over this, because the ventilator is not just going to push this in no matter what, right? There's going to be some variability from breath to breath depending on if the patient is, accepting that breath or if they're not very accepting of that breath. But about this tidal volume the patient will get with each breath. And that affects our scalars. So when we're talking about volume control, you're going to see the front of a ventilator. So let's say you got a patient here, stick figure human, and they are intubated, unfortunately. They have bad pneumonia, so they have a breathing tube coming out of their mouth, and that breathing tube is hooked up to a ventilator, and you have the ventilator screen. And every ventilator is different, but a lot of ventilators have these 4 settings on the bottom of the ventilator. All right, they have the PEEP, the FiO2, the respiratory rate, and then this 4th setting, if we're in volume control, so if this is ACVC, this is going to be the tidal volume. And as we said, the uncontrolled variable here is the pressure. So often in the top right corner, you'll have a peak pressure, which is the pressure that the ventilator is experiencing each time it pushes in this tidal volume, or the cc's per breath of air that you're setting. And on the front of the ventilator, oftentimes they show scalars. And these scalars are usually pressure over time, flow over time, and volume over time. And these scalars are going to look different depending on what mode of ventilation you're in. And it is important to understand how they differ with each mode of ventilation, and you can also identify the mode of ventilation a lot of times looking at the scalars. So that's what we're going to talk about next in the video, is the scalars that you will see in volume control, or assist control volume control. The first one here is pressure versus time. So pressure on the y-axis, time on the x-axis. The second is flow over time. And the third is volume over time. And in volume control, the scalars you see are determined by how the ventilator is delivering the breath. All right? The volume scalar is the easiest to understand, so that's what we'll start with. So what you have with each breath, this is a single breath here. So this is one breath. And as you can see, the volume goes up for half the breath as the ventilator is delivering that breath, and then it goes down for the other half, right? That's as the patient is expiring. So this is inspiration, this is expiration. And this volume should be about what you set on the ventilator. It should be about that tidal volume. So if you set 400 cc's, each one of these breaths should be about 400 cc's of air. And you can see that repeated, right? Inspiration, expiration, inspiration, expiration, right? And this should be about 400 each time. And this would be 3 breaths, right? 1 breath, 2 breath, 3 breath. And this looks similar between volume control and pressure control. You get about, the tidal volume is going to be different, but the scalar itself, the shape of it, inspiration and expiration is about the same, right? Because the volume goes up when they inspire, the volume goes down when they expire. And it goes, hopefully, to 0, right? Because you hopefully breathe out all the air you breathe in. And then when there's no air going in, when they're between breaths, you just have this volume at 0 because they're between breaths, right? Breath 1 in, breath 1 out, no breath. Breath 1, breath 2 in, breath 2 out, no breath. Breath 3 in, breath 3 out. So that makes sense, right? That's an easy one to understand. What about these other 2 scalars, though? You have flow and pressure. So as we said, when the ventilator delivers a certain volume, the ventilator is going to experience a pressure, right? Because if you push air into the lungs, there's going to be a pressure that develops that the ventilator senses while it's pushing that air in, all right? And that's going to vary depend on the cycle of the breath. But something to know about volume control is even though you're setting a tidal volume, the ventilator is actually targeting a flow. And this is going to make sense in a second. So if we talk about ventilators, oftentimes there's 3 things we think about with each breath. The trigger, or when the ventilator decides to give a breath. The target, or what the ventilator is targeting, because it needs to target something, right? It's a ventilator, it's not a human, it can't think. So you have to tell the ventilator, I want you to target X with this breath. And then the cycle, or when the ventilator stops the breath. So the trigger, when the ventilator decides to start a breath, the target, or what it targets during that breath, and then the cycle, when it decides to stop a breath. And in volume control, the trigger is time. Makes sense, right? We said we set a respiratory rate. If we set the respiratory rate at 20, that means that every minute, every 60 seconds, the ventilator is saying that that patient needs to get 20 breaths every 60 seconds, or about 1 breath, right, per every 3 seconds. And ventilators are smart now, and this is assist control, meaning the patient can also take their own breaths, and that counts towards the 20. But if the patient is not taking their own breaths, every 3 seconds, the ventilator says, I need to give a breath, or that's my trigger. If there's not been a breath in 3 seconds, that triggers me to give a breath. So time is what triggers the ventilator to start a breath. We're going to skip target and come back to it and go with cycles. So what then causes the ventilator to stop a breath is the tidal volume, and what the ventilator targets is the flow. And this is where things get confusing, but if you understand this, you'll understand the scalars, or possibly vice versa. So let's pause. I told you in volume control, you're setting a tidal volume for the ventilator to give with each breath, right? But I just then told you that the ventilator's targeting a flow. Well, what's that about? Why wouldn't it target a tidal volume, right? If I said, give it a certain tidal volume, why wouldn't it just target the tidal volume? Well, it is in a way, but it's in an indirect way, because what causes the ventilator to stop a breath is the tidal volume. So if I tell the ventilator I want that person to get 400 cc's of air with each breath, the ventilator says, okay, I get that. I am going to target a flow. So flow is the amount, it's like cc's of air per unit of time. So if I say I want the patient to get 400 cc's, let's just do 500 because it's an easier number. The ventilator goes, no problem. I know that if each breath that I'm giving, I'm just making up numbers here, each breath that I'm giving is going to be 1 second long, and I need to give 500 cc's, I know how much air to flow in that second. It's 500 cc's per second. Let's just say the breath is going to be 2 seconds long. right? So if the breath is 2 seconds long, the ventilator says, no problem, 500 over 2 seconds is going to be 250 cc's of air per second. And that's what I'm going to flow in, because this is, air cc's per unit time seconds. So what the ventilator actually targets is this flow. It's the cc's of air per second, because it knows then that it will give the tidal volume I'm setting over the duration of that breath. So it will give 250 cc's per second for the 2 seconds until it gets to the tidal volume I set of 500 cc's, right? 250 times 2. And then it will cycle. It will say, stop the breath. That's the tidal volume they wanted. Breath is over. And this then translates into why our pressure and flow scalars look the way they do. Because if you look over here and start with flow, what you see is flow is flat on the top, whereas pressure ramps up at the top. Now, why would that be? Because we are targeting a set flow. So over time, right? So the ventilator says, okay, 250 cc's per second of flow. I'm going to just ramp up immediately to that set flow of 250 cc's over, 1 second time, and then the flow just immediately goes to 0. This is inspiratory flow. And then this is negative because the patient's starting to expire. So this portion here, the positive portion, is inspiration. This portion here goes all the way down to the negative portion is expiration, because this here is 0 flow. Right? So now there's no flow when the breath is done being expired out until they inhale. You get your set flow rate. It holds that flow, 250 cc's per second. Okay, I got my tidal volume. I got to my 500 cc's of tidal volume. I'm going to just drop the flow, right? It just goes all the way back down to 0. But then the patient starts to breathe out and expire until it goes back to 0 when the patient's breathed all the air out. Right? And that's why in volume control, this top area is flat on top, because the target is a flow rate. It's a constant flow rate until you get to the tidal volume that you set, and at which point the ventilator stops flow and the breath is over. And that's also why you get this ramped up pressure, because if you give a set flow rate, it's going to slowly build up the pressure in the lungs. Right? You got 2 lungs here. You got a trachea that goes into these lungs, and I'm pushing air in, and that air has to expand the lungs. But the lungs, they have a compliance, right? It takes effort to expand those lungs and overcome the lungs' compliance. But that in turn creates pressure pushing back, right? Because those lungs are expanding and kind of pushing back as they expand. And that's what causes the pressure that is created. And, peak and plateau pressures and things is going to be a different video. But when you set a set flow rate, that's going to slowly, as it flows air down and pushes those lungs out, build up an increasing pressure as more air is delivered into the lungs until you get to that point where the breath is done. You can see these line up, right? Breath is done, at which point the patient expires, and the pressure drops back down to this set pressure, which if you watched our original video, this is the PEEP, the positive and expiratory pressure, which we won't go into here. Definitely check out that other video. And as you'll see, and we're going to link all these in the video description when we talk about pressure control scalars, this looks different than a pressure control scalar. This ramp up is characteristic of volume control because you have a set flow rate, and as that flow over a period of time, let's just again make it up, say it's 2 seconds, for every 1 second it's kind of pushing in 250 cc's per second, or you could break this down even further into milliseconds, but it's flowing a certain volume of air in per millisecond, and that is slowly filling up the lungs, increasing the pressure until that breath is over, at which point the patient expires and the pressure goes back to the end expiratory pressure that we set on the ventilator. All right, so this is very characteristic of volume control. You get this flat top at your flow scalar, you get this ramped up pressure scalar, and then the volume scalar is pretty constant between pressure control and volume control. It's pretty constant. So peak and plateau pressures. These are 2 separate pressures that the ventilator measures. And the reason they're separate is because they represent different physiologic findings, right? The measurement they are taking represents 2 distinctly separate things. The nice thing about peak and plateau pressures is it can give us a clue into the patient's physiology. In addition to that, we need to manage these pressures. We don't want them to go too high because they can cause damage. Things like barotrauma, where the lung gets too distended, the alveoli get too distended, and as such they get damage. But to further understand some of these concepts, it really is helpful to dive into what these pressures are representing. So if we scroll down, we drew a quick and dirty version of the lungs, right? Right side, left side. This is the trachea, the main stem bronchi, and all these bronchi obviously break up into smaller and smaller bronchi into bronchioles, and eventually if you were to zoom, way in, this would end in kind of these balloon-shaped alveoli, right? And these are kind of balloon-shaped alveoli. That's a really terrible drawing. Let's try it again. Terminal alveoli, and these are the little balloons that actually inflate and deflate for gas exchange. This blue thing here is an endotracheal tube, right? There's a plastic tube that goes into the trachea. You blow up a balloon here so it forms a seal, right? And the ventilator delivers a breath into the endotracheal tube, right? That breath comes out of the end into the trachea. It goes into both bronchi, and then it waves its way into all the bronchi and bronchioles into the alveoli, and then it inflates the alveoli and expands the lung, right? So this lung expands out. After the breath is stopped on the ventilator, right, the lung then contracts back in, and the air goes the opposite way. So it travels back out the main stem bronchi into the trachea, into the endotracheal tube, and then out the endotracheal tube towards the ventilator. Right? That's just the basics of how a breath is delivered on mechanical ventilation. So when we're evaluating a patient on the ventilator, let's just say you're prepping for rounds in the morning to present the patient to the attending intensivist, there's two pressures that we're interested in, right? The first is the peak pressure, and the second is the plateau pressure. And these are both pressures that you can get off the ventilator. The peak pressure is often in the top right corner. It depends on the ventilator brand, but the top right corner. And it's a pressure that you get with every single breath. Whereas the plateau pressure is something you actually have to test for. You have to do this inspiratory hold maneuver that we'll talk more about to get the plateau pressure. So what are these? Starting with the peak pressure is the pressure the ventilator is experiencing when it tries to push a breath into the lungs. So ponder that for a second, right? This is a closed circuit, right? This endotracheal tube ends up coming out of the patient's mouth, and then there's kind of tubing that weaves away onto the ventilator itself. But this is a closed circuit. It's not open to the external environment, right? From the tubing to the endotracheal tube, there's this balloon that causes a seal into the lungs. So when this ventilator delivers a breath, the breath travels through the tubing, through the endotracheal tube, through the bronchi, and into the lung tissue. And the pressure that is required to flow that breath through the tubing, the endotracheal tube, these airways, and inflate the lung is the peak pressure. And that's why you get it with every single breath. Because when the ventilator pushes that breath in, it says, oh, this is the peak pressure that I experienced while I was trying to inflate the lungs on that breath. So if we think about what that means is it's really a manifestation of the airway resistance and the alveolar resistance, because those are the two things that are happening. The breath is traveling through the airways, and then it's inflating the alveoli. So the resistance of those airways and the resistance of those alveoli are what is going to create the pressure that ventilator experiences while it's trying to deliver a breath. Right? If we just make this more simplistic, let's just picture you had a pump, right? Here's your pump. It's got a little nozzle at the end, and that nozzle is kind of plugged in to a pipe, right? And then there's a balloon on the end of that pipe. The peak pressure would be the pressure it takes you to pump a breath through this pipe into the balloon and then start to inflate the balloon. Right? If you're blowing into that, the amount of force you have to push in, the pressure required to flow the air through that pipe and inflate the balloon is the peak pressure. And that is why it's a manifestation of the resistance of those airways to the breath flowing through them, as well as the alveoli resistance as they try to inflate. So really the peak pressure is airway and alveoli resistance, okay? Now, as we talked about, it's detected when the breath is being delivered, right? Because it's an airway resistance. As the breath is flowing through these airways, that is when it detects the peak pressure. And do note that this is all in volume control. This is more of kind of an advanced topic and probably outside the scope of this video. But there's different modes of mechanical ventilation. There's volume control, there's pressure control, there's SIMV, there's APRV. There's all these different types of mechanical ventilation where you can deliver breaths differently. And peak pressure is really a discussion in this context for volume control, which is the most common modality of mechanical ventilation. Okay, and the acceptable norm, I put acceptable in quotes here because acceptable is not necessarily normal. Acceptable is what we tolerate without getting very concerned and having to adjust the ventilator settings. And the acceptable peak pressure is less than 40 centimeters of water. So when you look at the ventilator and you get this reading, the peak pressure, you're going to get a reading that says X centimeters of water, right? Maybe it says 33 on that breath, 32 on the next breath, 34 on that breath. And these are all pressure measurements, right, in centimeters of water. This is in contrast to the plateau pressure. The plateau pressure is detected with what we call an inspiratory hold maneuver. So essentially what we're doing is we are pushing a breath in, and then we are pausing the ventilator. We're not letting any air out of the ventilator, and we're not letting any more air go back into the lungs. So I'm going to erase all this, and we can see if we can kind of draw it. I'm going to redraw, right? The endotracheal tube comes out the mouth. There's this tubing, right out the mouth. There's this tubing, and it goes onto the ventilator. And again, this is a closed circuit. The idea that it's a closed circuit is really important. So when we deliver a breath in, as we said, the breath travels through the tubing, through the endotracheal tube, through the trachea, the bronchi, into the bronchioles, and then it inflates the lungs, right? It goes to both sides, obviously. The plateau pressure is the pressure experienced when this breath is pushed in, but not let back out. And you pause the flow on the ventilator. There's no air flowing in or out, right? So just picture it. It's essentially if you took your own breath in, and then you just held it in your lungs. You're not letting any air in, you're not letting any air out. But you can almost feel the pressure in your chest when you do that, right? Because your lungs are inflated, and your lungs are tissue. So as the air is pushing those lungs out, the lungs are also pushing back in. They're trying to deflate back down. And if you're not letting any of that air escape, the plateau pressure is the pressure that the vent is feeling as those lungs try to deflate when we won't let them. It's an inspiratory hold. So as one might assume then, that plateau pressure is more representative of the lung compliance. The compliance being how easy those airways are to kind of distend out and collapse back in. You can also think of it as kind of an alveolar resistance and lung compliance measurement. So if we think about what this is saying, the plateau pressure is actually sort of a part of the peak pressure, right? Because as we said, the peak pressure is when we push an air in, and part of the peak pressure is airway resistance, but the other part of the peak pressure is we have to inflate those lungs, right? And if we're saying plateau pressure is lung compliance, the force that the lungs are trying to push back in on that breath, you can think of the peak pressure as airway resistance plus lung compliance, plus the plateau pressure. The physiology there isn't perfect, but it's somewhat helpful in understanding these two things. Because when we think about peak and plateau pressure, we're going to talk about kind of highs and normals. An acceptable plateau pressure is less than 30, right? And that's acceptable again, because that's not necessarily normal. If you put a healthy person on a ventilator, their peak and plateau pressure would be very low, right? So this is acceptable. This is what we think is okay and will not induce a significant amount of barotrauma or overinflation or overdistension of those alveoli. So the difference between these two, the peak and plateau pressure, is important. Because if they are the same, right? If the peak equals the plateau pressure. Let's say the peak pressure is about 30, and then you do this inspiratory hold, and the plateau pressure on the inspiratory hold is also 30. That is really saying that most of the pressure that you're seeing in the peak pressure is simply lung compliance, and that there's not much airway resistance, because lung compliance and airway resistance make up the peak pressure. Right? Does that make sense? So if the peak pressure is proportional to airway resistance, right, we'll just say airway R, and lung compliance, lung C, and we're saying the plateau pressure
is proportional to lung compliance, if the peak equals the plat, that just means that all the peak pressure is lung compliance and the airway resistance is not contributing. That's in contrast to if the peak pressure is greater than the plateau pressure. So let's just say the peak pressure is 50 and the plateau pressure is 20. Well, now this changes, right? Because if we're saying the plateau pressure is 20 and the peak is 50, we can essentially say that, well, 20 is related to lung compliance, but the other 30 left is airway resistance. And this can be helpful when understanding the pathophysiology going on, because these two represent different things. So anytime the peak pressure is high, the second question is, what's the plateau pressure? And if the plateau pressure equals the peak pressure, this is really a lung compliance problem. If the peak pressure is greater than the plateau pressure, it's really an airway resistance problem. And both could be high, and it could be a both problem as well, but the differentiation between the two is important in deciding if it's an airway resistance problem or a lung compliance problem. Because airway resistance and lung compliance are going to represent different things, right? So as we mentioned, let's say there's a high peak pressure and a high plateau pressure, right? So peak pressure is 30, let's make it 50, plateau pressure is 50, that's very high. Well, remember what we said. If the peak and plateau equal each other, this is really just a lung compliance problem, because the plateau pressure is lung compliance. And if the plateau equals the peak, that means airway resistance is not playing a big role, because we said peak pressure is airway resistance and lung compliance. So if they equal one another and plateau pressure is just lung compliance, again, means airway resistance isn't playing a role. So then we think about the things that cause an abnormal lung compliance. And that is the pathophysiology that's leading to that high peak and high plateau pressure, abnormalities in lung compliance. And those abnormalities, easy way to think about it is kind of blood, water, pus, inflammation, fibrosis, right? Blood being things like hemoptysis. If you have blood within the lung parenchyma itself, hemoptysis isn't the disease, but it can be caused by a number of things, right? DAH. It can be from any type of arterial bleeding in the lung, right? So blood in the lung can cause abnormal lung compliance, right? Because that blood gets in all those alveoli, clogs them up, doesn't allow them to distend as they would normally, right? Water, so things like pulmonary edema, P edema, can cause an abnormal lung compliance. Pus being infection, so things like pneumonia. All right, inflammation can be from anything. Let's say you have pneumonitis from, maybe you aspirate and you have aspiration pneumonitis. Maybe you're on a, some type of chemotherapy agent that causes medication-induced pneumonitis. So any inflammation in the lung. And then fibrosis, right? Fibrosis can cause the lungs to have decreased lung compliance. So maybe it's like interstitial lung disease causing fibrosis. So if you remember these, that gets you through most of the things that can cause an abnormal lung compliance. The other thing is if you're not ventilating all the lung like you think you are, right? So if you intubate someone and you accidentally mainstem them, right? Meaning the endotracheal tube is actually going into just one of the main stems. That means you're not really ventilating this lung. So you're trying to push all the tidal volume into a single lung, and that will lead to a high plateau pressure because that lung is exerting that much more downward pressure as it is trying to accept that full tidal volume. Similarly, if you had lung collapse of a certain area of lung, that would cause higher plateau pressure as well because you're ventilating less lung than you think you are. Or if you haven't had a pneumothorax, a popped lung, let's say this lung's totally collapsed because there's a pneumothorax. Again, you're just ventilating one lung. And the amount of tidal volume is the amount of tidal volume, right? Let's say you set the tidal volume at 500. That tidal volume is supposed to go into both of the lungs, right? And if it's only going into one of the lungs, so instead of getting 250 and 250, this lung's got a pneumothorax and is collapsed down. That means now you're trying to put 500 cc's of tidal volume in that one lung, and you're going to over-distend it. You can think of it like a balloon again, right? If you're pushing 250 cc's into a balloon and then you try to push 500, that pressure, that compliance that it's coming back down with is going to be more robust. Okay, so if you're not ventilating both lungs the way you think you are, whether you main stem the intubation or have a pneumothorax or have some degree of collapse, then otherwise this blood, water, pus, inflammation, fibrosis are the things that can cause abnormal lung compliance, which is the high peak and high plateau pressure.
And this is just to echo, right? Because the peak pressure of some of the ventilator just tells you on each breath. So if that peak pressure is high, the second question is always, what's the plateau pressure? So do that inspiratory hold. It's a button on a ventilator. You hold the button and it pushes a breath in and then it holds it and it tells you what the plateau pressure is. Because the plateau pressure equals the peak pressure, then you know it's a lung compliance problem. Whereas if the plateau pressure is normal, it's low, so it does not equal the peak pressure, cue this other one, we know it's an airway resistance problem. I feel like I'm repeating myself over and over, but this is just to really drive home the point, right? Peak pressure is both airway resistance and lung compliance, because the peak pressure is the pressure the ventilator is experiencing when it's pushing a breath in through the airways and inflating the lungs. Whereas the plateau pressure is just a lung compliance problem, because the plateau pressure is when the ventilator pushes a breath in and then holds it, doesn't let any gas flow back and forth, right? And then that is just a representation of the lung compliance. So if it's a high peak pressure to normal plateau pressure, you already know the lung compliance is normal, right? So you're taking this out of the peak pressure equation, so you know all that's left is airway resistance, so you have an airway resistance problem. And anytime you have an airway resistance problem, what you want to do is you want to trace the circuit, I call it. Because remember what we said. We said you have a ventilator, and you have ventilator tubing. And that tubing then attaches to the endotracheal tube, right? And that endotracheal tube is going into the lungs, into the trachea. The endotracheal tube's got a balloon here and a balloon here, and it is creating a closed circuit for your lungs. So if you have airway resistance, that does not just mean airway. That could be resistance in the endotracheal tube. It could be resistance in the tubing. So the first thing you always think about is endotracheal tube pathology. Is there a kink in the tubing? Is the patient biting the tubing, making it more smaller, making it more small? Is the endotracheal tube too small to start with? Is there mucus built up, right? Because all those things are going to increase airway resistance. I'm just going to draw an endotracheal tube, right? If you're trying to flow air through this endotracheal tube, and let's say there's mucus built up on the side, you got a big Goomba right there. Now that air's trying to flow by a smaller area, and that's going to lead to more resistance. Or let's say the patient's kind of biting down on the endotracheal tube. So instead of this nice flat surface, you have this huge kink in the side because the patient's biting down on it. Again, you're going to have to try to flow that air past a smaller surface, and that's going to cause higher airway resistance, a higher peak pressure. So the first thing to do is to trace the circuit, trace the endotracheal tube. If the circuit and the endotracheal tube are all okay, well then you actually are having a true airway problem. And just like the endotracheal tube pathology, the problem with the airways could be mucus plugging, right? You could have mucus built up in one of the airways, just like you could in the endotracheal tube. Now you're trying to push air past mucus built up in the airway, smaller area to push it through, higher airway resistance. You also could have bronchospasming of the airways itself. Maybe the patient has COPD or they have asthma, right? And those bronchospasms is when those bronchi kind of spasm down, right? Creates smaller amount of area to flow that air through, higher airway resistance. Maybe there's a foreign body in the area. Maybe the patient has ventilator desynchrony. They're not being cooperative with that breath and they're kind of pushing back on it. All those things can cause high airway resistance. So again, high peak pressure. Second question is, what is their plateau? If it's a normal plateau pressure, then you know the lung compliance is normal and you have an airway resistance problem. If it's a high peak pressure and a high plateau pressure, then you know it's a lung compliance problem and not an airway resistance problem, right? And that similarity between the two is if they're within about 5 centimeters of water. Now, if they are both high, right, let's say the peak pressure is 60 and the plateau pressure is 40, they're still different enough where you have an airway resistance problem, but you also have a lung compliance problem because they're both high, right? We said acceptable plateau pressure is less than 30, and we said an acceptable peak pressure is less than 40. So they're both high, but the peak is higher than the plateau. So we know that you have both a lung compliance problem and an airway resistance problem. All right, so if you think about it that way, it sticks a little bit better, I think. And then last but not least is just the scalars. If you don't have an interest in this or don't have the background, this certainly isn't that important. But this is a pressure versus time scalar. This is something that shows up on the front of the ventilator screen. And remember, this is in volume control. And you can see here that this is 0 for the pressure. The peak pressure is going to be the peak pressure that the ventilator experiences when it's pushing a breath in, right? So this is where it's starting to push a breath in, and then it gets to this peak. And this is what the ventilator is putting on the side of it, right? This is 30, the peak pressure is 30. The plateau pressure, though, as we said, is a maneuver you have to do. So I wonder if I take a marker, I'm just going to draw over this so we can draw something fresh. Just pretend like it's the same color as the other ones. So if you do an inspiratory hold, right, a patient takes a breath, they have the peak pressure, and then you have an inspiratory hold, the ventilator will go like this. This is when it's holding the breath. And then you let go, goes back down to 0, and the patient can take their normal breath again. Okay? This here is the plateau pressure, right? This portion of the inspiratory hold. So that is literally on the scaler will give you a pressure. You know, if this is 30, let's say maybe this is just 20. Nice normal plateau pressure. And it will kick this out on the screen too. There will be a little area that says plat, and then it'll give you a number like 20. But you have to do the inspiratory hold, right? You have to hit the button. And our respiratory therapist will do this. Certainly shouldn't be doing it too much on the ventilator without the respiratory therapist, especially if you're early on in your training. But you have to do an inspiratory hold to get the plateau pressure, whereas the peak pressure is just that peak pressure at the end of each breath, and that's an automatic thing the ventilator reads.
Enough of the shameless plugs. Let's dive into driving pressure. What is driving pressure? Well, driving pressure is a variable that we can determine when someone's on mechanical ventilation, okay? It represents the pressure difference needed to inflate the alveoli during each breath. And we're going to come back to that as a concept. Okay, so it kind of represents this interaction between tidal volume and compliance of the respiratory system. And it's really emerged as a marker for lung stress and possible risk for ventilator-induced lung injury. If we were to kind of try to bring it down to a lower level, it's kind of the amount of pressure the ventilator uses to quote-unquote open the lungs beyond their resting state. And this definition will make more sense, I think, when we start to talk about the equation for it. We'll loop back around to it. It depends on how your brain works, but sometimes understanding the equation, how to calculate it, then helps us better understand the concept behind it. So, good transition. How to calculate driving pressure. So there's two main formulas depending on the data you have. One of these is the most common. So we're going to start with the less common formula. And the less common formula, if you know the compliance, is that driving pressure is actually the tidal volume divided by compliance. And this is a representation of what driving pressure is, but is not as clinically useful. The more clinically useful equation, which is the one that most people use, is that driving pressure is the plateau pressure minus the PEEP. And this equation is best applied to a patient who is passive, so they don't have a lot of ventilator desynchrony or interaction with the ventilator, and they're on volume control. So they can't be spontaneously breathing, they can't be desynchronous. This has to be a patient on volume control who's fairly passive. They're not interacting much with the ventilator. And what you have to do is you have to get a plateau pressure. If you do not know what a plateau pressure is, this video is probably a little beyond where you're at. We have a whole playlist on all things mechanical ventilation where we dive into plateau pressure. It's linked in this episode's description, so definitely check that out and then return to this. For those of you who do know what a plateau pressure is, friendly little reminder, you have to get a plateau pressure with an inspiratory hold. And this you kind of set on the ventilator, right? You click a little button and do an inspiratory hold, and this essentially means there's no flow of air going through the airways. You pump a breath in and then you just hold, and you check the pressure. And this is more representative of things like lung compliance or alveolar compliance. And the driving pressure then is the plateau pressure minus the PEEP being the positive end expiratory pressure. And if we really think about this, what we're saying is I'm going to push a breath in and hold it, which is going to help me just see kind of alveolar pressures, lung compliance. And I'm going to subtract the PEEP from that. And it's going to give me a number. And the lower the number, the better, which essentially means the higher the PEEP and the lower the plateau pressure, the better. Whereas if the plateau pressure is going up more than the PEEP is going up, the driving pressure will be higher, and that is worse. And we're going to circle back around to this, but I want you to kind of picture that. And maybe we'll do it now and we'll talk about it again in a second. So when we think about the plateau pressure and we think about the PEEP, lower driving pressure is better. So the plateau pressure minus the PEEP, we essentially are saying that you have this alveoli. And this alveoli is experiencing the PEEP that we set, the positive vent expiratory pressure, right? This is the pressure that's there all the time, both inspiratory and expiratory. And if we set that PEEP at 5, that is going to cause the alveolus to be distended to a certain amount. And then we check a plateau pressure. And if that alveolus is perfectly distended, that plateau pressure, that inspiratory hold, that pressure that's reflective of alveolar distension, is going to be probably low. And we're going to have a low plateau pressure, and the driving pressure then is going to be lower. Whereas if we have an alveolus that is over distended because there's too much PEEP, the PEEP's at 15, that plateau pressure is going to be really high. And if we play around with this in our brains, let's say that we have a plateau pressure. Let's say the plateau pressure is 20 and the PEEP is 5, okay? And that's a driving pressure of 15. And we're like, oh, well, actually, let's change this. Let's say the plateau pressure is 30 and the PEEP is 10. That is a driving pressure of 20, right? Driving pressure is plateau pressure minus PEEP, 30 minus 10, driving pressure of 20, okay? And we're going to draw an alveolus if you're watching the YouTube video, and that alveolus is here, okay? And let's say we're like, goodness, is this the right amount of PEEP? Could they be under-distended, under-recruited, or over-distended, over-recruited? And I think, based on my clinical assessment, that they are under-distended, right? I think this alveolus is kind of collapsed down, and they're under-distended. So what I'm saying is, I think if I go up on the PEEP, that will cause the alveolus to be perfectly distended, which means that the plateau pressure won't really change, because I'm just going from kind of an underdistended, shriveled down alveolus to a normally distended alveolus. So what this would look like is I increase the PEEP from 10 to 14, and I let that PEEP take hold, and then I check another plateau pressure. And that plateau pressure maybe is 30 again. And now what I'm saying is, okay, my driving pressure is 30 minus 14, because that's my new PEEP, and that is a, 30 minus 14, yeah, because that's my new PEEP, and that is a driving pressure of 16. Whereas at a PEEP of 10, that driving pressure was 20. So I went from a driving pressure of 20 down to 16, which then tells me that that PEEP change was good. Changing that PEEP from 10 to 14 just helped recruit more alveoli, that before they were under-distended, because the plateau pressure didn't really go up much, even with an increase in PEEP, which made that driving pressure go down. But if we take the other scenario, right, we're going back to they're at a plateau pressure 30 and a PEEP of 10. And I think I'm like, oh, I think they're under-distended. So I increase that PEEP to 14, like I did. So the PEEP goes up, again, 10 to 14. But I was wrong. They were not under-distended. So now this alveolus is super over-distended at that PEEP of 14, and I check a plateau pressure. And that plateau pressure is probably, 36 now. So if I do a driving pressure now, 36 minus 14, that driving pressure is now 22. It got worse. It went up. And that tells me that that PEEP change is just over-distending alveoli. It's causing more barotrauma. It was the wrong thing to do, if that makes sense. We'll come back to it. All right, so what does it mean clinically? What does the driving pressure mean clinically? Well, as we mentioned, lower driving pressures suggest that less force is being used to inflate the lungs. And this often indicates the lungs are at a better compliance, more optimal compliance, whereas higher driving pressures mean that there's more force needed to inflate the lungs, and the lungs have kind of a lower compliance, aka stiff lungs or over-distended lungs. So lower driving pressures are quote-unquote good. Higher driving pressures are quote-unquote bad. And driving pressure is a surrogate for what's considered kind of lung stress, strain, associated ventilator-induced lung injury. So that higher driving pressure can suggest that those lungs are sustaining ventilator-induced lung injury, and we got to make some changes. So when we use driving pressure, the things to think about are lung compliance. And there's two different ways to think about this. Actually three different ways. One way is following the driving pressure to better understand how lung compliance is changing. So if you are not changing the PEEP, but the driving pressure is getting worse or getting better, it suggests the lungs are getting more or less compliant. So again, just scenario, the plateau pressure is 20, the PEEP is 5. Your driving pressure is 15, right? Driving pressure is 15 because it's your plateau minus your PEEP. And you haven't made any adjustments, but you check a driving pressure the next day, and the driving pressure the next day is 22. That's probably too robust of a change, but you get the point. What you're essentially saying now is the compliance has changed. Something's going on. Maybe the patient is developing worsening ARDS. Maybe they're having progression of illness because the driving pressure has gone up even though you haven't changed the PEEP. That suggests that the plateau pressure is going up. Same thing in the opposite direction, right? Let's say your plateau pressure is 30 and you're at a PEEP of 10. And for whatever reason, that's the best you could do. Your driving pressure was 20. You don't make any changes, but you check the next day and the driving pressure is down to 15. That essentially means that plateau pressure is getting better and the compliance is getting better. Whatever illness was going on is improving. Okay, so if you're not making adjustments, honestly, you can track the plateau pressure too. But a lot of times things are a little more complex, and driving pressure can be a helpful surrogate, but it can be an indication of how the lungs are evolving from a compliance standpoint, either worse or better. Okay, so assessing lung compliance. You can also use the titrate ventilator settings, and I think that's what a lot of us do now, especially in ARDS. You can try to find an optimal tidal volume and PEEP to achieve the lowest driving pressure. And that's kind of what we were talking about, right? You can do PEEP titrations while checking driving pressure intermittently to see if the patient is, if their alveoli are optimally distended. And there's fancy things like stress index, which can help you understand this. But essentially, you're trying to get the alveoli to the most optimal amount of distension by titrating their PEEP either up or down, right? If you think they're over distended, you want to titrate the PEEP down. If you think they're under distended, you want to titrate it up. But the driving pressure will help you understand if you made the right decision. Because if that driving pressure goes down, that means your PEEP titration was good. If your driving pressure goes up, that means your PEEP titration was wrong, and you should think about going in the other direction, whether it be up or down. And then predicting outcomes, we don't use this as much, at least personally, but elevated driving pressures are associated with increased mortality in mechanically ventilated patients. So if you were to think a little bit about the evidence, this is just as of this video recording, there's certainly other evidence out there. But in 2015 New England Journal of Medicine, there was a landmark meta-analysis of patients with ARDS, and this is when driving pressure kind of came more so into the forefront. And it found that driving pressure was more strongly associated with mortality than even tidal volumes or PEEPs. So it suggests that reducing the driving pressure may improve survival in these patients with ARDS. There's been subsequent studies that kind of support this concept that you should be targeting a lower driving pressure, not just tidal volume or PEEP. But most of these are associative studies. There hasn't been, at least as far as we're aware, these robust RCTs, although they probably will be coming, so stay tuned. When we think about important clinical considerations and caveats, again, this is really only valid during passive ventilation. If the patient is breathing a lot on their own, they're desynchronous, what have you, you can't really do this. It confounds the measurements. You need a plateau pressure to do this. So you have to measure the plateau pressure appropriately or your driving pressure will be off. And just remember, this is affected by chest wall compliance. Although the driving pressure takes some of that out of the equation, it still does take it into account a little bit. So clinical takeaways here and then key summary points. Driving pressure is a powerful, easy to calculate variable that does reflect lung compliance and injury risk, especially in ARDS, and targeting that driving pressure of less than 15, that's your magic number, less than 15 is what the evidence would suggest may be correlated with more improved outcomes. Okay, key summary points, I think we're there. Driving pressure formula is plateau pressure minus PEEP. You want it to be less than 15. Higher driving pressure implies poor lung compliance and increased ventilator-induced lung injury risk. Best used in ARDS management. And remember, the patient has to be passive or you cannot get an accurate measurement of this. Hopefully that was helpful. Let us know what thoughts, comments, questions you have. Again, check out that Patreon page, YouTube, podcast, weekly newsletter, and we have a whole mechanical ventilation series that will link obviously in the description on this episode, so check those out too. Either way, we appreciate y'all. Stay well, keep learning. We'll see you next time. Today, we are going to be talking about how to present a patient on mechanical ventilation on rounds at the hospital. This will be interesting for anyone who works in the clinical arena, whether you be a student trainee or anyone who just is presenting on rounds or thinking about how to present on rounds or wants to even figure out how to maybe teach how to present on rounds. In addition to that, it could be interesting to the general public too, for those interested in loved ones who unfortunately found themselves on mechanical ventilation and some of the things we think about. So the goal here is to show everybody how to thrive, how to impress on ICU rounds. We haven't done a video or a podcast like this before, so certainly let us know what you think, if this is helpful and interesting, or if it's a complete and utter waste of time. We hope it is the former, not the latter, but obviously we do all this to try to help out you all, so if it is not helpful, we definitely want to hear that. We will upload this as a study guide to our Patreon page. We'll put up some practice questions too. Early access on our YouTube members page, and then as just a friendly reminder and shameless plug, we do have that weekly newsletter that we put out as well. And then you might be listening to this as a podcast, because we're podcasting now, or you might be watching it as a video. So either way, we appreciate you. No further ado, how to present mechanical ventilation on rounds. So the start of this tends to be with an organization or a structure to how you want to present the different parts of relevant data related to mechanical ventilation. So you have a patient and they are intubated, okay? Maybe, is it a sad face or a happy face? I guess we'll say it's a sad face. And you are the one pre-rounding on them. You need to collect certain data. And the data you need to collect on pre-rounds is actually a lot, and this is a robust, right? There's a comprehensive look. Not saying you got to present this on every patient every time on rounds, but this is kind of a comprehensive approach. And the data you really need is you need to know their mode of ventilation. Are they on volume control? Are they on pressure control? Are they on something different like pressure support? Maybe they're on an SBT trial. You need to know their ventilator settings, particularly things like PEEP, FiO2. All right, is it volume control? What's their tidal volume? Or are they on pressure control? What's their inspiratory pressure? You need to know the respiratory rate. Depending on their physiology, sometimes you need to know things like I to E time. We're going to talk more about all this. Then you do need to know their peak and plateau pressures. Recent arterial blood gases. What your goals are is important to know and have. Recent chest x-ray findings, and then what you want to do with all that great data you collected. All right, so that's kind of the basic foundations of data collection. These are the things we're going to be talking about in terms of how to collect the data, how to think about it, and how to present it. So if we start with number one, mode of ventilation. The common modes to know, and we've talked about this in the past. We got tons of videos on mechanical ventilation linked in our mechanical ventilation playlist, so check those out if this is confusing. But the common modes to know are volume control and pressure control. These are the two main modes of mechanical ventilation that we use. Pressure support is important to think about too if they're on it, right? Spontaneous breathing trial patients, when you're trying to liberate them from mechanical ventilation, often have a pressure support trial. SIMV people still talk about, but this is not commonly used, so we're going to cross it off there. So the two main ones with kind of a third possible that you need to know are volume control, pressure control, or pressure support. So if you're on rounds, it's important to start with, patient is on volume control, or patient is on pressure control, or patient is on a pressure support trial, right? So that is number one mode of ventilation. Number two is going to be ventilator settings. Okay, and there is somewhat an order to this madness. People probably don't really care too much about the order, but there is some degree of formality to the order, which we'll talk about. But ventilator settings are the next thing to know. So you already identified maybe your patient is on volume control. They're on AC, VC. All right, now what settings are they on? And the settings to think about are respiratory rate, tidal volume. If they're on pressure control instead of tidal volume, you need to know your inspiratory pressure, and then your FiO2, your PEEP, and I to E ratio sometimes, which we'll talk more about in a second. Okay, but when you're thinking about this on rounds, usually we have respiratory rate followed by tidal volume, followed by FiO2, followed by PEEP. Okay. When you do present their tidal volume, if you want bonus points, you can say what cc's per kg of ideal body weight it is. So this might look like, patient X is on ACVC. Ventilator settings are 18,450, which is about 6 cc's per kg of their ideal body weight. FiO2 40%, PEEP of 8. If someone has
obstructive lung disease or kind of a deranged IDE ratio, normal being about 1 to 2, it is important to say that because these things can get lost track of sometimes. So let's say they're on an IDE ratio of 1 to 4 because they have a bad COPD exacerbation. You can then add that IDE ratio at the end, right? So patient X is on ACVC. Mechanical ventilator settings are 18,450, which is about 6 cc's per kg of ideal body weight, FiO2 40%, PEEP of 8. Their IDE ratio is still 1 to 3 for their obstructive lung disease. Okay. If you have a attending or someone who's thinking about stuff and they're really quick, sometimes they don't even want you to label things. They just want you to say 18,450, 40% and 8, just in this order, rather than saying PEEP of 8, FiO2 of X, tidal volume of X, and respiratory rate of X. But that's somewhat person dependent. It's always easier to start by saying what things are, and you can always take out those labels if that's what people prefer, right? So maybe say patient X is on volume control with a respiratory rate of 18, tidal volume of 450, that's about 6 cc's per kg of ideal body weight, FiO2 40%, PEEP of 8, their IDE ratio is still 1 to 3. All right? You still with me? So we've done 1 so far, mode of ventilation. We've done 2 ventilator settings. Let's keep stacking on. So peak and plateau pressures. This is the next thing, and this is starting to get next level. A lot of people can do 1 and 2 with the mode of ventilation and settings. But once we get to 3, this is where we really start to impress and start to really understand things a little bit better, which is important too. And the pressures you're most interested in are going to be the peak pressure and the plateau pressure. And remember, the peak pressure and plateau pressures, this is really for volume control settings. You can't really get, it's not easy to get accurate numbers if someone's on pressure control. So this is for volume control settings. All right, the peak pressure differs with each breath, and it's usually shown on the ventilator screen somewhere. So every time a breath's pumped in, often it might be in the top right corner. You got kind of your ventilator screen. You might get your peak pressure up in this top right corner, but it depends on the brand of ventilator that you have. But a range is okay. Let's say their peak pressures have been kind of 30 to 40. All right, write that down and record that. Then their plateau pressure. Their plateau pressure, you actually have to do an inspiratory hold maneuver. Not that we are suggesting you should go do a bunch of stuff on the ventilator. Certainly make sure you're following whatever protocols your institution has. This is often recorded in the chart by respiratory therapy every so often. But you can do it bedside too. It's really easy. You just do an inspiratory hold. Okay. And then when you do that inspiratory hold, it'll usually pop up somewhere on the ventilator screen as plateau pressure. All right, and that's a singular number. Let's just say the plateau pressure is 24. Okay. The last kind of pressure that can be important to document and to present, and this is really next level, is the driving pressure. And we don't want to go into what exactly driving pressure is, but it is a surrogate for possible kind of optimal PEEP, and the goal is less than 15. All right, the goal plateau pressure is less than 30. The goal peak pressure, there's some variability here, but less than 40 is probably a reasonable number. So if we were to present 3 peak and plateau pressures, you know, you might say something like peak pressures have ranged from 30 to 40. Plateau pressure this morning was 28, and the driving pressure is 14, or the driving pressure is 20. All right, and if you were to connect all those, now we got 1, which is mode of ventilation, we have 2, which is settings, and we have 3, which is pressure. And you might say something like, patient X is on volume control. Their current settings are a respiratory rate of 18, tidal volume of 450, which is about 6 cc's per kg of ideal body weight. Their FiO2 40% is their PEEP of 8. Their IDE ratio is still 1 to 3. Their peak pressures range this morning from 30 to 40. Their plateau pressure, when I checked this morning, was 28, and their driving pressure is 14. All right, things are getting a little more tricky. But yes, peak and plateau pressures are the next things to add on, and then driving pressure is a nice bonus. This is particularly helpful if you have a patient in ARDS, okay? All right, step number 4. Now we're going to add on the arterial blood gas. Now, this is something that should be reported, in our humble opinion, when you're presenting mechanical ventilation. It might come up in your plan elsewhere too, but when you're presenting data, the most recent ABG is important to know. You don't necessarily need an ABG all the time for each patient, but the most recent ABG, if it's within the last 24 hours, is important to present. And typically we present the pH, the PaCO2, right, which is the partial pressure of dissolved carbon dioxide, the PaO2, or the partial pressure of dissolved oxygen. And the bicarbonate comes on the ABG too. We personally don't usually present the bicarbonate, but you certainly can. And the SpO2 and the pulse ox tox can be relevant. You could present that too if you would like. The order in which these are presented is usually pH followed by PaCO2 followed by PaO2. And if you do bicarbonate, bicarbonate's at the end, although again, we don't tend to do bicarbonate. So you might say, if you're presenting the ABG, is most recent ABG was from 3 hours ago, the pH was 7.34, PaCO2 is 48, or PaO2 is 82. If you really want to go quick and you want to take away the labels, you just got to make sure that everybody knows what you're talking about. But you could say something like the most recent arterial blood gas was done 3 hours ago. It demonstrated 7.34, 48, and 82 would be a reasonable way to present that too, as long as everybody's on the same page, which not everybody always is. All right. When you are interpreting this, just remember that the PaCO2 is a marker of ventilation, which is respiratory rate and tidal volume. The PaO2 is a marker of oxygenation, which is usually PEEP and FiO2. And we'll talk a little bit more about that. So we're going to stack all these together. Hopefully we don't start to forget things. We certainly might. But you could say patient X is on volume control. Ventilator settings are 18,450, which is about 6 cc's per kg of ideal body weight. 40% and 8. Their ID ratio is still 1 to 3. Their most recent peak pressures this morning were between 30 and 40. Plateau pressure was 28 and driving pressure was 14. They had an arterial blood gas from 3 hours ago. It was 7.34, 48, and 82. All right. We're getting more complex. I'm sure at some point we're going to have to edit out how we forgot some of the details around the patient. Let's go to step 5. This is oxygenation and ventilation goals, and this is not necessarily something you have to explicitly present because the team probably knows this, but depending on the clinical scenario, sometimes you do want to present this. You can briefly state targets. Sometimes you're doing things like permissive hypercapnia. Sometimes you're allowing some degree of kind of lower oxygen saturation. Sometimes you're doing different lung protective strategies. So if you're going to present the goals, it's easy to do it after the arterial blood gas. You could say things like achieving desired oxygenation with an SpO2 greater than 92%. And we are allowing for permissive hypercapnia in the setting of ARDS. Again, this is somewhat of an optional step. But it can be useful depending on the clinical scenario if you're not necessarily targeting the most standard endpoints. But we'll leave that out of our long presentation, and then we'll go to step 6, and then we'll do 5 and 6 together. So step 6 is the most recent chest x-ray. Many patients who are on ventilators get chest x-rays every day. You don't necessarily have to, but that's a discussion for another time. People have differing opinions on that. But if you are getting chest x-rays, it's really important to present the endotracheal tube location, how many centimeters above the carina it is, right? The carina is where that trachea bisects into the right and left bronchi. So that is important. Also, any kind of infiltrates, consolidations, atelectasis, certainly pneumothoraces are all important to present too. So you could say something like, most recent chest x-ray was from yesterday evening at 11 p.m. The endotracheal tube is 4 centimeters above the carina. There were bilateral infiltrates consistent with pulmonary edema. And then it's always really helpful to include a comparison to the previous. So you could say something like, this looks to be improving as compared to the x-ray from 2 days ago. So now let's see, we got step 1, which was mode. We have step 2, which was settings. We had step 3, which was pressures. Step 4, hopefully we're not making everybody not want to do critical care medicine. Step 4 was ABG. Step 5 was kind of targets for oxygenation and ventilation. Step 6 is chest x-ray findings. So let's see, if we were to do all this, you'd say patient X is on volume control. Their current ventilator settings are a respiratory rate of 18, tidal volume of 450, which is about 6 cc's per kg of ideal body weight, FiO2 40%, PEEP of 8. Their ID ratio is still 1 to 3. Their inspiratory pressures or peak pressures this morning range from 30 to 40. Their last plateau pressure was 28 with a driving pressure of 14. They had an arterial blood gas from 2 hours ago. It demonstrated pH 7.34, PaCO2 of 48, PaO2 of 70. They are currently achieving their targets for ventilation and setting a permissive hypercapnia as well as oxygenation. Most recent chest x-ray was from 24 hours ago. The endotracheal tube was 3 centimeters above the carina. It did demonstrate improving bilateral infiltrates that we thought was pulmonary edema as compared to the chest x-ray done preceding that.
All right. Hopefully we didn't miss any parts of that when we were saying it out loud. We didn't prep these ahead of time, so we're doing them in real time. And last but not least is the clinical assessments and plan. This is where you go from just reciting the information to actually interpreting it. This is the wrap-up interpretation. Now, sometimes this is best done in the plan. Okay, when you're presenting on ICU rounds, usually you present the data first, and then you go into a plan. So our practice pattern is to put all this in the plan, and if you're going to do that, just say, once you're done talking about the ventilator, we'll talk about adjustments, and if you're doing a head-to-toe presentation, so you can talk about adjustments in respiratory or in pulmonary, but just speak that out for everybody so that they're not anticipating you're going to talk about the plan there. If someone wanted to talk about the plan there, in our mind, it'd be a little bit out of order, but certainly you could. But the things you're kind of thinking about are every day for every patient, are they ready for a spontaneous breathing trial? This is absolutely critical. You should explicitly say yes or no, and if the answer is yes, they should get a spontaneously breathing trial. Obviously, are they improving or worsening? Do you need to adjust any of their ventilator settings? Any signs of patient-ventilator desynchrony is important to think about too, okay? So this might look like in your plan, you already went through the whole ventilator, and you say something like, patient has had improving oxygenation, they're currently on an FiO2 40% of PEEP of 5, they're ready for a spontaneous breathing trial, which we will do this morning. Or this could be, the patient has had worsening hypoxemia in the setting of interval chest x-ray that showed a new pulmonary infiltrate. They are not ready for spontaneous breathing trial as their FiO2 is up to 80%. We're going to increase their PEEP from 8 to 10 to assist in oxygenation, and they are having a lot of ventilator desynchrony secondary to their tachypnea. We're going to, do XYZ depending on what the desynchrony is. So if we are going to connect steps 1, which was mode, step 2, which was settings, step 3, which was pressures, step 4, which was ABG, step 5, which was are we hitting our goals, step 6, which was chest x-ray, and step 7, which was clinical assessment, which is usually in the plan. We would say something like, patient X is on, and we're just going to use, we're not going to use the abbreviations, we're just going to use the order of things. So patient X is on ACVC 18, 450, 40%, and 8 with an I to E of 1 to 3. Peak pressures are 30 to 40, plateau of 28 with a driving pressure of 14. Most recent ABG from 1 hour ago, 7.34, 48, and 68. We are achieving our goals of SpO2 greater than 90%. Most recent chest x-ray was from 3 hours ago. Endotracheal tube was 3 centimeters above the carina. There was improving bilateral infiltrates as compared to the chest x-ray yesterday. And then forwarding to plan, patient has had improvement in oxygenation. They're ready for a spontaneous breathing trial, which we'll do this morning. They're comfortable without any ventilator desynchrony. All right. Hopefully that wasn't too much, but it is a lot. But this is next level presenting on rounds. This is, would be absolutely fantastic. If we were to go down, I think we wrote out an example too. We did. For the plan. This is something, if we were to kind of say the clinical assessment and plan, you could say something like the patient's oxygenating well on FiO2 40% and PEEP of 8. Their plateau pressure remains less than 30. ABG shows mild hypercapnia, accepting in the setting of ARDS strategy with permissive hypercapnia, no acute changes on the chest x-ray. Plan to continue current settings and reassess readiness for SPT tomorrow. Another example of a plan. So quick tips for success. Always start with mode and settings. And really, this is all about repetition. Stick to a single structure and just do that every day for every patient over and over and over again. All right, use objective numbers, but then in the plan, interpret them clinically, right? So when you're presenting the numbers, just be objective. Don't use soft language like, their FiO2 is around 40-ish%. Really use objective. Their FiO2 is 40%. But then when you're interpreting them clinically, you can interpret them. But when you're objective, stay objective. And when you are interpreting, you can come up with a plan and instill some subjectivity to that plan. Tailor your focus in the plan for whatever you're treating. Is it ARDS? Is it COPD? And be ready to talk about the settings they're on, suggest weaning escalation, and always talk about are they ready for their spontaneous breathing trial. Anyone on a ventilator, the goal is always to liberate them from that ventilator.
Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.